Welcome back, one and all, for our second guest lecture on the topic of value addition to forensic medicine teaching in CBME through collaboration and integration. To chair this session, I call upon Dr. Somashekar S., Professor, Department of Forensic Medicine, KAHERS, Jawaharlal Nehru, Medical College, Belgaum, and Dr. Udaya Shankar, Professor, Department of Forensic Medicine, Saptagiri Institute of Medical Sciences and Research, Bangalore.
Now we hand over the session to the chairpersons.
Good afternoon, everyone.
I thank organizing committee for giving this opportunity. And I would call upon the next resource person, Dr. Runda Bhatt Kamath ma'am. She had completed her MBBS from Al-Amin Medical College, Bijapur in 1997 and MD from Kasturba Medical College, Manipal in 2001. Currently, she is working as professor and head Srinivas Institute of Medical Science, Mukka, Mangalore. And along with the teaching experience of Indian, she has 2 years of teaching experience from Libya. She has several national and international publications to her credit. And she is involved in ongoing study on assessment of understanding of sexual harassment in adolescent age group in undivided Dakshin Kannada district. Also, she has few best papers to her credits as from conference oral presentations. She is an active member in medical education and she is serving as a medical education since 2001. And she is a curriculum committee member in RGHS, a resource person to train medical faculty and postgraduates. As well, she is an NMC observer for the revised basic workshop. And she was editor-in-chief for the KAML's journal from 2004 to 2008. And I know her personally in academic field, and her hunger for the teaching and learning is unending. Over to you, ma'am. Thank you.
Thank you so much, Dr. Somashekar and Dr. Uday. A very good afternoon. I know a post-lunch session is something like a post-prandial session, but I will try to make it as lucid as possible, as interesting as possible. As Dr. Somashekar said, my journey in the field of medical education started right from the time I entered into the field of forensic medicine. And at the very outset, today I am what I am because of these 2 godfathers in my life. Professor A. Krishna Rao sir, under whom I got trained. I even today, talk about the various sessions, and Pradeep sir is there here who will tell us. Every Friday evening we used to meet and we used to be, rigged on to present various sessions in medical education. Not only that, today if I am somewhere near to be called as a teacher, it is because of Krishna Rao sir and my godfather and also a medical educationist, Yoga Narasimha sir. So I dedicate this presentation to them because it was a dream for Professor A. Krishna Rao sir to have an integrated curriculum for the undergraduate students. And he had made us, given thoughts to us right from that day, 2001, to make subtle changes in our day-to-day teaching so that, the students benefit at a larger, pace. So today I'm going to talk about forensic medicine and toxicology in CBME curriculum and how collaboration and integration is going to help our subject reach better to the general public. In my talk today, I'm going to touch upon certain things, because they say that, CBME has become like an elephant in the room. Everybody knows it is there, but nobody wants to speak about it. Maybe because of fear, or maybe because of not knowing what it is, not knowing how to proceed. Year 2010 was a dark year in the life of forensic experts or forensic medicine faculty, because that was the time when there was a big rumor saying that NMC is going to dissolve forensic medicine, if I'm not wrong, right? 2010, 2011. And that is when all this, the senior faculty, including our Balraj sir, who took the forefront, and a national association was created. And we went in the forefront in such a magnitude that, in Educon, in your, under Dr. Nagesh, September when we had Dr. Avinash Supe, who had given a fantastic talk. And when we raised an issue about something in relation to forensic medicine, he said, you forensic people, you are a very strong team nationwide. You can get what you want because you know how to fight for it. Yes, we fought for it. We wanted the implementation of Vision 2015. Unfortunately, it got postponed to 2017. And finally, in 2019, we got what we wanted. A CBME curriculum. Well, I don't know how many, I'm not sure how many of us wanted it, but definitely, yes, a clinical position for forensic medicine. Forensic medicine no longer was restricted to second year subject, whereas we got 2 years of teaching of forensic medicine. And then started the downfall. Before, when Arun contacted me for this talk, I thought this was a right podium for me to do a small kind of, within the pilot study kind of a thing. So I, at random, selected a few colleges where I had certain, question mark in my mind whether actually CBME is being practiced or not. I did not take many colleges, some 10 to 15 at random. So many of you may not have known about those Google forms, and some of you are aware of that, those who responded to it. And I was surprised at the, the feedback that I got through these Google forms. We wanted this change from preclinical or paraclinical subject to clinical subject, but we were not ready to step up to that level to make it effective clinical subject. I'll just take you through the talk and let me tell you where all the things are. So first, right now, let me just tell you the certain things that I'm going to discuss. First and foremost, I'm going to talk about certain terminologies because everybody knows that these terminologies, but what exactly they mean, how they need to be implemented in this teaching learning methodologies is still a big question mark. Then certain excerpts from the Graduate Medical Education Register 2019 records, the GMER which brought out in 2019, certain things in relation to collaboration and integration, what was being said, and then what are the departments. See, NMC has given us a list of objectives, competencies, saying that these are the competencies, these are the possible teaching learning methods, and these are the departments with whom it needs to be integrated. So that is just a suggestion. Dear friends, please note that that is just a suggestion. Nobody stops you from, thinking out of the box and making a difference in the life of the students. You don't have to exactly stick on to those. And so that is why I'm going to tell you something which I am actually practicing since 2019. I'm actually practicing it since 2019. So I'm going to share certain ideas with you. So that will be my other objective, ways and methods to align and integrate with the collaborating with the other disciplines. So at the very outset, we all know what is alignment. Can anybody just tell me? We have heard about this. Integration, alignment and integration, AI. Very commonly, not artificial intelligence. In relation to medical education, AI means alignment and integration. What is alignment? What is alignment? Stand in a queue. That is alignment. In the same phase, it means in the same, when the student is learning in a particular year, how much time it takes for us to teach the same content which the pathology is teaching, or which the pharmacology is teaching, or which microbiology is teaching. It's not a big deal. Now, in some of the responses when I had asked, do you integrate with integrate and align the subtopics with your phase-wise? The response I got was, I don't know why people said that you cannot align with ENT, opto, and community medicine. What about second year? We are taking 50 hours of classes in second year. What about those 50 hours? Can't we align there? And there is nobody stopping us from aligning with community medicine at least. So that is possible. So alignment simply means it has to be done in the same time frame along with that means a content area. Either you can do it topic wise or system wise. If pathology is taking cardiovascular system, sudden deaths can be incorporated here. Those things are needed to be done. So that is called as alignment. And then we have integration. Integration means vertical integration. So in Though there is two types of integration, vertical and horizontal. Horizontal is called as alignment and vertical integration is left the terminology as integration on itself. So anything in a single teaching session, it can happen. I can get a medicine person here and talk about myocardial infarction, sudden deaths. I can get a pathologist also, and we can in a divided session, we can take a class, or in a small group discussion, we can take a session. Or we can talk with, we can discuss with pharmacology in the second year, or even in third year, we can request them to come and discuss something about some toxicological, some poisons, or some snake bites, organophosphorus. So many areas are there where we can take these teaching sessions. And then there is another entity that is known as a linker session. Anybody has an idea what is a linker? A scenario, a case. It is not only that case, it is that case is taken up and all the departments that are involved sit together and discuss that, so that a student has a complete entity about what. Otherwise, what is happening in the current scenario in our traditional teaching? Biochemistry will teach something about it, pathology will teach something about it, and by the time the student is in final year, that is when he will realize the importance of biochemistry, anatomy, and physiology. But there is nothing he can do to come back and learn it again. Because at that time, he was never told the importance of those subjects, that how it is going to help him in his future. So these linkers are, linker can be a case scenario. It can be simply a blood report. It can be a PM report where a doctor had treated a patient, and after that, in a medical legal case, the death has occurred. So the PM report, it can be anything wherein multidisciplinary faculty come and sit and discuss it with the students. It is something like, a total meal being given to the student as a wholesome. So that is a linker session. The GMER 2019 10.2 clause says, integration must be horizontal and vertical. Horizontal meaning alignment and vertical meaning integration. And this vertical integration should not be more than 20% of the content area. Just because CBME or NMC has said do integration doesn't mean you go on integrating with everything. Today I'm going to do this. Okay, you come, pharmacology come. Tomorrow pathology come. Day after tomorrow medicine come. The other day surgery come. No, it is not like that. Not more than 20% of the content area should be vertically integrated, giving us the scope to teach our subject in our own method. At the same time, it says that the alignment should be at around 80%. That means the rest of the area where you are not able to vertically integrate, at least do the alignment. Let the student know about CVS in totality from pharmacology. Let them do the CVS drugs. Let pathology teach about the histopathology of the CVS. Let microbiology teach about the organisms affecting the heart. And let us talk about sudden death and other manifestations, myocardial infarction, and how to find out the cause of death in those cases. All those things. Let there be an alignment. It need not be the same week. See, the NMC doesn't say that when you're doing it, everybody has to do it the same week. No, it just says in the same block. We have divided into blocks or units, as is in some of the colleges. They have done it either in units or in blocks. So whatever it is in that given block, let there be some kind of an alignment for the student to know what is happening in that particular system. And then clinical cases used to integrate and link using the linker. So this is told very clearly in the clause 10.2 under GMER 2019. So this is the traditional teaching. Whoever wants, they can take whatever topic they want. Each department is doing its own. That is what was happening till 2018 batch. Then they said, you do horizontal. In the same phase, you can see that all the subjects are talking about the same system. And the vertical across the phase where the same topic is being taught. Now, you can say that, when anatomy is going on, how can we talk about medicine? How can we talk about surgery? How can we talk about pathology? All right, fine. But second year onwards, medicine is there, surgery is there, OBG is there. We can at least align there. Integration, there are different levels of integration. different types of integration. Integration simply does not mean I'm taking a class today, I'm getting a forensic medicine, I'm getting an internal medicine faculty in my class, and we are integrating. That is not the only form of integration. So let me just tell you what is integration. It is just a learning experience for the student to know that if I am knowing about a particular concept, how is it going to benefit me when I am in actual practice? When I'm actually practicing medicine, how is this content area going to help me? So it is a unified view of its basis and application. All right. Whereas the act of making it whole lies on us. It is our duty to not to see when somebody, now I love cooking. All right. I love cooking. So I thought I'll take that as an example because I can see many female faces here. So I thought they will relate it better with me in relation of that. See, our current training is like this. Okay, in first year, we teach them one part of the elephant. All right, maybe 2 parts. In second year, another 2 parts. In third year, another. In fourth year, another. In totality, they never understand that they were learning about the elephant. So that is why the interpretation is, when first year they studied, they thought it is a spear, because they are blindly learning things. They're blindly learning things. Some concepts explained in first year. So this person says the ears are fan, the ivory tooth are the spears. Then another person says the legs are like a tree, the body is like a ball, the tail is like a rope, because they have been fed in bits and pieces, and nobody bothered to open their eyes and tell them that we are helping you to describe an elephant. And by the time their blindfold is removed, when they are in their internship or they're actually practicing, they realize it is an elephant and they don't know anything about that elephant. That is what is happening here. So to avoid that, it is simply said that Harden was the person, along with his team, in 1984. He said, the organization of a teaching matter to interrelate and unify subjects. There's no point in individually giving things to students. It is good, but you have to tell them where it is useful for them. Frequently taught in separate academic courses and in departments need to be unified, and that is what he said is integration. So how can we do it? Let me just tell you one more thing. It is not only on the shoulders of our we teachers, but it is also on the shoulders of the students to learn this in a unified way. We just had food. Arun, you didn't serve this. Otherwise, I thought we will have an example of this. But anyways, those who love this can have a feast of it through your eyes. Not allowed here, but I'm sorry. Please, excuse me for using this picture. Oh, they have resumed. So the virtual now and then actual in the night it seems. So savor it as much as you can here. But remember one thing. This dish looks beautiful. But tomorrow, if somebody is asked to cook a biryani, see, now I have prepared biryani, take it. This is how biryani is prepared. If I tell them, does it make any sense? Student will do it on his own without even knowing. So what we do in traditional curriculum, first year we teach them how to prepare rice. In second year, we teach them how to cook chicken, egg. Third year, we teach them the spices. What are the various spices that are needed to be done? We never tell them to mix it. So what happens? Finally, the student ends up eating them separately. Can they enjoy the biryani then? Eating rice separately, chicken separately, eggs separately, spices separately. Is it going to make them savor the biryani? No. We have to teach them while boiling rice. This is how you boil the rice to prepare biryani. Now the student knows it. These are the spices what you are cooking to be added to the biryani at that stage. When we tell them now, they will learn it better. Not when we are in the third year, we are teaching them the spices, they have forgotten how to cook rice. That's a fact. So tomorrow they are ended up with only with spices and they don't know how to cook biryani. Because in the first year we taught rice, second year year we taught chicken and egg. By the time third year, they realize the importance of biryani, only spices are there in their hand. And they're not in a position to cook the biryani. So right from the day one when we teach them that yes, this rice needs to be cooked for biryani. This is how you cook. This is the importance of cooking rice. They will understand it better. I hope I have touched a small chord somewhere in the understanding of why integration and alignment is required. That is the essence of it. Otherwise, we will all end up eating them separately, thinking we are actually eating biryani. So integration is basically of two types, as I've already said. The horizontal, and they are all based on the topics, organs, cases, whatever, in whichever relation it is. Not necessarily in the theory class. It could be a clinical posting. It could be a small group discussion. It could be AdCom. And those are the things that I'm going to really talk about. Because, let me just complete this slide, and I'm going to talk about something very, very important. The horizontal like in the same face, and the vertical across the face. So these are the two things that you're going to listen, hear frequently now in this session. Same face and across the face. Now, 2 years, immediately after the Corona lockdown, in last year, January, somewhere January to February, the UGMEB board, the UG Medical Education Board, they held a lot of meetings with all the institutes, and there was no concrete circular released from the NMC. Just remember this, no concrete official circular was released from the NMC. Every college which underwent the meeting brought out their own minutes of meeting and said that these were these words that were told to us by Mrs. Aruna. So it became that the circular was from Mrs. Aruna, so it sticks. No, absolutely not. One of the most important concepts that was brought out was SGD and AdCom has been cancelled. How many of you believe it? Come on, I have got the responses in my Google Forms, and they have written that SGD and AdCom module has been cancelled and been converted into lecture mode. Please note that she had simply said that it is up to the discretion of the college how many sessions. It is not cancelled. Even now you are expected to conduct SDDs, SDLs. SDL is self-directed learning, small group discussions, and AdCom modules are a must. That is the whole crux of CBME curriculum. The entire crux of CBME curriculum is in these small nuances, not the lecture. Lecture, it will be, we are reverting back to the traditional method, and we don't want that. I know it is very convenient. You go for a big class, finish the portion in 1 hour, and then you are done. Small group discussion, same thing you have to repeatedly take. Dear friends, I'm a one man, one human or one woman army in my department. I have 2 batches, one of 155 students, another of 125 students, around 300 students, and I single-handedly still managed to take small group discussions, AdCom modules, theory classes, self-directed learning. Luckily, yes, I am a bit luckier than you people because my institute does not have medico-legal work as of now. But other than that, I'm doing everything. I am also into medical education. So it's not a difficult task at all. It is simply, a big elephant has been kept and people are simply scared as to what it is. And it is one of the most lovable animals. Elephant is one of the most lovable animals until and unless you try to poke it. Just let us enjoy that thing. So I'll just tell you how are the things. Vertical integration has to be done in this format. They say that from the basic sciences, 80% of the content area should be alignment, 20% should be the integration. Similarly, as it goes, that is how it is being decided. So finally, what we want is alignment and integration. So that when a student goes into the final year, he is learning the actual medicine in depth. He knows how to refer back to the basic science subjects, preclinical and paraclinical subjects. Now, I was speaking about Hardin, and he was the one who brought out this concept of integration. And he proposed a ladder, like Pradeep sir had morning given us the ladder of hierarchy in our professional career. This is the hierarchy the students have to undergo during their undergraduate days. Now, starting from isolation, awareness, harmonization. Isolation is traditional, pure traditional curriculum. We don't know what the other subject is doing. Anatomy doesn't know what physiology is doing. Physiology doesn't know what biochemistry is doing. Total isolation in the content area. That is the lowest and almost not to be there in the ladder itself. Then comes awareness, wherein we know that, okay, we are speaking, during tea break. We just talk, okay, what topic are you doing? Okay, serious. Oh, you're doing serious. I'm starting serious in the second semester, not now. So now there is an awareness as to what is being taught in the different subjects. Whereas harmonization comes a little better. Okay, you're doing CVS next month. Huh? Okay, let me see whether I also can do CVS at that time. Still, they are not into integration. It is just by, creating a self-awareness and then trying to align. So after that comes the important. So I'm going to talk about the 4 steps, important 4 steps of integration, which is a must to be inculcated in our curriculum. And that are the nesting, temporal coordination, sharing, correlation. These are the 4 important areas of the ladder, rungs of the ladder, which needs to be implemented in the curriculum. Now, I hope that most of the faculty here has undergone medical education workshop, revised basic course workshop. Anybody here who has not undergone the revised basic course workshop? Yes, sir. Thank you, sir. But, it is like the God himself saying, I have not undergone it. All right. Okay. Yes, sir. Yes, sir. He doesn't have the certificate, but he gives the certificate. So, anyway, how many of you know what each of these are? Because this is definitely taught. CISP workshop, curriculum implementation support program. All ABCDs, EFGH, all alphabets were used. CISP workshops. All right. It's in 4 pieces. No, my hands are cramped because of the cold. No, it's okay. My hands are cramped because of the cold. Because the AC is a little too much here. All right, no issues. CISP workshop was the one which spoke about alignment. Thank you. Which spoke about alignment and integration. CISP workshop? Anybody undergone? All right. But here I'm seeing blank faces. What is she talking about? Thank you. All right. So integration and alignment was spoken about it there. And obviously the medical education department, when they speak, they will give the department their own subject examples, and we come out empty-headed because we don't have any correlation to what is happening. So I thought I'll just do this a little deviate from the regular session and take up how I am doing. I'm not telling this is how it needs to be done. I am going to tell you how I have been doing nesting, sharing, temporal coordination, correlation. I'm going to give my personal examples here and trying to, put across what exactly it means. So let us start with nesting. Nesting doesn't take anything, doesn't require any help from any clinical department. No clinical department, no preclinical department, nobody's help. Not even the paraclinical other departments. Nesting simply means you tell them the applied aspect of the topic that you have dealt with. For example, in anatomy, if they are dealing with the CVS, or in physiology, when they are dealing with the ECG, they tell there, when you practice medicine or when you go to general medicine, ECG is important because it helps you to detect the various changes occurring within the heart. You tell them that. You tell them how it will be different. Give them an example. Tell them this is a nice to know area. But show them it, because see, no matter what, until and unless you give an example, people will not understand. People will not understand until and unless you give them an example. So give them an example and make them understand. So that is called as nesting, where the teacher does the duty of the clinician or the preclinical teacher or the other departments of the paraclinical teachers. That is called as nesting, where the teacher herself or himself teaches the relating aspects of the other subject, other skills or whatever are required. Now, how am I doing this? I take this example from the curriculum, our curriculum book, FM 12.1, describe features and management of abuse with cannabis, amphetamines, cocaine, hallucinogens, designer drugs, and solvent. In the book, it is given vertical integration with internal medicine. Now, if I contact them, they will say, I have a lot of patients, madam. Your class is on Monday. Monday, we have full patients. It's not going to be possible for me to, come and take a class. So that doesn't mean that I will not integrate. I will take that topic and I will tell them how it is going to be important to know it when they deal with an actual case of a drug abuse being brought to the casualty. What are they supposed to do? What are they supposed to look for? What are the drugs that they are supposed to know? How to handle such a case in case of emergency. So I will take a lecture and I will explain them. So this is called as nesting, where the teacher, the forensic teacher herself or himself takes the class and explains the applied aspects of the. So vertical integration with internal medicine is happening without the medicine, general medicine physician being present in the classroom. So that is one form of integration. Nesting, where the teacher, but everything cannot be nesting, please believe me. Everything if you do in nesting only, students after some point, they will start losing interest. Temporal coordination. Again, this is something similar to alignment, where whichever subject, let it be here, it is vertical and horizontal. Whichever subject is taking the class, let there be the same topics being conducted. As much as possible, preferably in the same week. So that when a topic is taken in forensic, the similar topic is taken in pharmacology, a similar topic is taken in general medicine, the student by the end of the week has a complete picture of the importance of that topic. Now let me give you an example for that, how I do. Now temporal coordination, for this I will have taken up these three competencies. From internal medicine, it is enumerate local poisonous snakes and describe the distinguishing marks. From forensic medicine, describe general features, basic methodologies in treatment of poisoning. They have combined everything here. Okay, they have combined everything here. And even snakes are also there in that. And then there is one in pharmacology, describe management of common poisoning, insecticides, common stings and bites. So it is like everything together. So I spoke to the internal medicine person and I told them that I am going to talk about organophosphorus in this particular, area. I am going to talk about organophosphorus carbamates. I told the same thing to pharmacology. I told the internal medicine people that I'm going to do this. I'm going to also talk about the snake bites. We're going to do this topic in 3 weeks. We're going to do this topic in 3 weeks. So what did I do for temporal coordination when it was not possible for them to come to my class for the week 4 of the timetable? I put it like this. This is another example where in pathology is aligning with surgery. And again, here, the surgery is also aligning the topics with pathology. Whereas forensic medicine, I have written it in the timetable itself. Alignment with pharmacology for 1.52. I am dealing with 9.5. The next day, pharmacology was taking that topic, which was an alignment with these. And on the Saturday, the internal medicine was taking the 20.1 in alignment with me. It is depicted in the timetable now. That means I'm making sure that the temporal coordination is happening. The teachers are going to their own classes. But now what has happened is, because already the content is known to the student in relation to other subjects, most of the topics can be just mentioned as a passing remark. Whatever pharmac related are there, it was mentioned in a passing remark because pharmacology was already doing it. Internal medicine was also already doing it. So that were all, so I concentrated in my topic, whatever necessary in forensic part, I contributed, telling them that a similar thing is there being dealt in pharmacology and internal medicine. And it happened. This happened for 3 weeks, 3 continuous weeks. Similarly, pathology was also aligning with surgery in one particular, the same week. Again, that is called as temporal coordination. So that is an example of temporal coordination where, because nowadays it is required, the full year timetable has to be put up in the website. So if it is put, automatically the teacher will look into the timetable, okay, I have to do this topic today. Automatically it will get aligned. Automatically there will be a temporal coordination. Then there is a sharing where two or more departments plan together and talk about a particular content area. What better topic than forensic psychiatry? Forensic psychiatry, we talk about mental health act. We talk about true insanity and feigned insanity. How much of actual practice or actual cases have we seen to tell them that? We haven't seen a single case of feigned insanity or true insanity. Who better than a psychiatrist himself to come and take that topic? So that is the example that I'm going to talk here. That is the 5.6 FM, where Indian Mental Health Act 1987, with special reference to admission, care, discharge of a mentally ill person. It was in vertical integration with psychiatry. So in the third year, I took a class initially describing them about the various aspects. I introduced the Mental Health Act, and then the psychiatrist, that is Dr. Mithun from our institute, he came and he spoke about the amendments in the Mental Health Act. He spoke about true insanity, feigned insanity, giving his personal life experiences. I spoke for first 15-20 minutes, then he spoke for another 15-20 or maybe 30 minutes. And the students afterwards, when we took the feedback, the students enjoyed that class because their real life experiences were spoken of. So they understood the concept of true insanity, feigned insanity, and the amendments to Mental Health Act, because a psychiatrist came and told them how it has affected this amendment, how it has affected them. So this is how sharing is done, where in an actual class we can stand and do. Sometimes sharing can also be done if the doctor is not able to come, if the physician is not able to come. You can bring in a lab report. Yesterday I was just walking into the lab, I saw this lab report, and today we are talking about this particular disease, the diabetes. This is the lab report. How are you going to now tell me what is the inference from this lab report? So that is also sharing, where you are sharing something. Now your biochemistry is involved, general medicine is involved, and pharmacology is also involved. So that is how integration by sharing is done. This is one of the examples that I do in the college. Then we have what we call as a correlation. Now, if this you follow this particular diagrammatic representation, it will tell you that one concept is taken. This is something like an ideal integration method for linker. Ideal integration method for linker session, where a case-based discussion involving all relevant departments. See, in the hospitals, morbidity meetings, mortality meetings and all happening, right? Then there will be case presentations on some diseases, treatment protocols. So same thing, let it happen in front of the undergraduate student, not so extensively though, but pertaining to the curriculum of the undergraduate students. That is what is required here to be done. Now, I took the example of this ABO blood grouping. Now, in the curriculum, it is said to integrate with physiology and pathology. Now, we have a very beautiful, fantastically run forensic science department under us in Srinivas. And we have some very eminent teachers there and a very beautiful lab with all the amenities. So I took their help also. We took the classes individually, all the departments, a little bit session about it. And then we did what is known as a DOAP session. What is a DOAP session? Anybody? Demonstrate, observe, assist, and perform. That means a student is required to first we demonstrate it, then he observes it, assists it, and then performs. And believe me, the students, we first took a class on that individually, and then the students were made to do it. We took the help of the forensic science student faculty, we took the help of the pathologist faculty, and in our lab we did it. And the student was so happy. See, this hardly takes one small group discussion, 1 week of small group discussion. We may think that 2 hours of that session are wasted, but imagine the amount of information the student receives, perceives, hands-on. So this is how the correlation can be done. I have gone one step ahead. If you have remembered in the ladder, The topmost is multidisciplinary, which is usually seen in postgraduate level. But here, I have gone to the level of multidisciplinary also, wherein different subject specialists, not in medical, specialists outside the discipline of medicine come together. And it usually happens in conferences, symposiums. But what I did was, when the topic of legal procedure came, I contacted Mr. Nayak. He is the lawyer in SDM Law College. And I contacted him. He came and he took the class on the court proceedings, the medical evidence, all those things. It was heard from his own mouth. And when we are talking about fingerprints and other things, a retired DYSP, Mr. Hejmadi, Harish Chandra Hejmadi, he came. He delivered the lecture on fingerprints. What is the importance? Because he's a fingerprint expert. He was a crime branch DYSP, retired DYSP, and he was in the fingerprints bureau. So I did it multidisciplinary and also obviously with the forensic science people involved. So multidisciplinary is also possible, but yes, it takes a little intense. Probably personally, I know them, each of them, so they were kind enough to come and deliver those lectures. We are in the plan of making a MOU with the SDM Law College for them to come and take a few sessions for us every year for the students. But it is possible. Multidisciplinary can also be incorporated. So dear friends, I'm going to tell you only one thing, that I don't know what hype it has been created that it is difficult, it is not possible to be done. It is possible to be done. It is very easy to be done. Only thing is that we have to remove it from our minds that it is difficult. Whatever we were doing so far, we are doing it exactly the same way. We are tweaking it slightly here and there by taking help from the others. So I had also asked them, those colleges who are implementing CBME, and I asked what helped them in a CBME curriculum. What were the things that they benefited when doing this integration? So yes, most of them replied this. This was the top answer, that we did not have to repeat it. Even the clinicians who came to us, they said, okay, our topic is also done, so I don't have to do it in my subject when I'm going to take it. So it avoided redundancy. That was the main aim of NMC. Then they said contextual learning, students were learning better. Yes, they were coming out with very good answers in the papers. And most importantly, there was relevant learning. They were learning what is expected from them in the real life. So the contextual learning was happening, and the correlation between the basic science, that when we say clinicals, even the management talks big, oh, clinicians, don't disturb them, they're very busy. All work is dumped on preclinicals and clinicals. I don't know how it is in your, sir, being the VC, but usually that is the, aura around the clinicians, that, they are next to God, so don't touch them. We don't have to disturb them. They have to take care of the patients and all. So that has broken to a certain extent, and there was a nice relationship maintained between the basic, and at least it happened in my institute, where the basic science and clinical science faculty had a good relationship developed, and better retention for the students. Because when they were, in fact, the clinicians told us that, during the clinical postings, when they were asking them about the lab values or other microbiological values and all, they were responding in a better way. So they were able to retain it better because it was a integrated sessions. And obviously, it promotes better faculty communication with each other and with the students. But yes, most of the colleges also told me that they were unable to practice CBME curriculum. Mainly being it is time consuming. It takes a lot of time. I don't know why it takes a lot of time. We were anyway doing practicals for 2 hours. We were taking one theory class. Yes, now the batches are also the same for the given number of students. Yes, we have an extra batch with us now. Agree. Because now we have the second year students and the third year students. Agree. But that is what we wanted, right? We wanted forensic medicine to be a clinical subject. So we can't, want to eat the cake but not bake it. No, it is not going to be happening. We have to, if we want to eat the cake, we have to bake it. So yes, time consuming. The planning part of it takes a lot of time consuming. Initial part of it. So that is the part. See, now I have finished my curriculum for the third year students. They are now ready for From Monday onwards, they're having their final internals. So now I'm done. That's why I'm really, now this time, till the next batch comes in March, this 3 months are my time. I have nothing else to do. I will sit and collaborate it with other departments. I will talk to them. So why there is time consuming? These 3 months are mine. I am going to utilize it in developing the integration, different types of integration. So yes, we can manage time. This, I don't know how it can be addressed. Less faculty. Most of the responses had this out. Less number of faculty. How much less it can be than saying single faculty in the department. You cannot say that there are only 3 faculty in my department, only 4 faculty in my department. I am alone. I'm doing it. Yes, you may think that this lady is crazy. She can do whatever she wants, but it is not that. You know, this subject we have come into either with passion or without passion. Now we have to cultivate that passion for the subject. And when we have that passion, see, imagine, I was just discussing it with some of the delegates. You know, Pradeep sir in the morning asked a very beautiful question. How many of us are ready to get treated by our patients, by our students? Frankly speaking, I am posing that question. How many of you here, God forbid, in the time of emergency, are ready to take the treatment from your current student? Not a single hand up. Is this what we want? Yes, no, now current, sir. That's why I said current. Current, yes, sir. Current situation. You are ready to take it. That means you are following something which the student should learn in the right way. Similarly, I'll put a question. God forbid in future somewhere us or our relatives end up being on an autopsy table. How much are we ready to make this person do the autopsy or do the medical legal examination and give a report which is going to help us? Are we going to trust that report? Nirmal, keep your hand down. You are at a different level. I'm just posing that because if we have that thought in our mind today, probably we will strive harder to, forget about anything else. If now my daughter is in 10, tomorrow if she wants to take up medicine, would I want her to be a good doctor or not? Forget about the current students under us. My own child, I would like my daughter to become a good doctor and I would like her to get a good teaching, good learning experience. How is it going to be possible if I don't practice it? So yes, less number of faculty, issues have been raised. I don't know when it is going to correct, but that should not stall us from implementing the CBME curriculum. Cooperation across the phases. Make an effort. Make an effort. Don't we make efforts with our neighbors, even though that person is a bit, thinking high, but when we do have good relation with our neighbors at home, then why can't we have that similar good relationship with our neighbors in the same phase or across the phase? Efforts need to be put to maintain the relationships. Yes, need to adhere to the timetable. I have seen so many colleges coming up with beautiful timetable, year-long timetable, with complete details in the timetable. This competency is dealt with, this competency, this SGD, everything. But in practice, the old traditional system is going on. In 2019, my own faculty, first year faculty said the same thing. Madam, you put whatever timetable you want, we will make it and give you. But please don't ask us to follow it. We are going to teach as we are going to teach because we can't do all this SGD, SDL and all those things. It is not possible for us. We don't have staff. And there were 5-6 staff in the department. They don't even have clinical work. They don't even have medical legal work. Their only job in preclinical is to take classes. But they were not ready. Because the thing is, they did not know what needs to be done. Then when we took sessions after sessions, now blindly it is being followed in my institute. I'm proud to tell that. Yes, it took a lot of efforts from my side, from my entire medical education team. We worked, we even told them that, a quarterly report has to be sent to NMC as to how the classes are taken. We used to simply sit there in the classroom and scribble. making them know that, we are making a note of it and sending it to NMC. Probably that fear made them practice it, but whatever they say, Sama, Dama, Danda, Veda, whatever methods, it was implemented. And I am happy that it is not, maybe not in totality, but yes, at least 90% of CBME curriculum is being implemented in my institute. It takes a little bit of a hard work. So not to adhere to timetable is not an option. And restricted duration of the course. This is the newer concept, newer excuses. 11 months are there, only 8 months are there. Our third year students had only 8 months. They came to us in April, now they are already leaving us. 8 months in total. We have to do it, nothing else to do. There were certain scenarios where some things which were not under our control, COVID came, things were not in our control, and it is the same faced by everybody around the country. So things, yes, they are all challenges, but they can be easily converted into advantages with a mere little effort. So finally, we think too much about effective methods of teaching and not enough effective methods about learning by the students. So CBME curriculum has taught about it, and let us implement it so that better learning happens. Thank you. I'm open for questions, if any. I know time is a bit of an excuse, but I'm not going to give that excuse.
Thank you, Dr. Vrinda Bhatt ma'am, for that motivation and showing us the value that can be added through collaboration and integration with other departments. Whatever it is, biryani or chicken biryani, we have to serve it. So let's.
Thank you, ma'am. Most of the points are very well covered, and it was almost like a workshop. The only thing is we didn't work on this on papers. I have few points to be shared as perceptions. And once we talk about medical educations, we always tell there is no bias. Okay, it is exchange of ideas and adjusting to ourselves and taking more ideas from the others. So with this, only a few points which I wanted to just share here was integrations. Once we say, many of you get confused with the classroom or it is integration of the teachers or the clinical scenarios. The integration should happen in the minds of the students. That integration of the concepts, what it has to be brought out in a classroom. Okay, it is not merely teachers coming together to teach two subjects. As the goal of our IMG, Indian Medical Graduate Course, okay, at the end of the course, the student should be able to be a doctor of first contact. So we all are same at the same stage. We know what they need to learn. We are not teaching them very high-fi things in the classroom. One thing. Second point, it is not actually, CBME is not something which scares us. It is a reluctance of ours to accept it. Okay, we feel resistance to change. So we need to change because it is in the gadget. Gadget can't be changed now. We'll have to just implement, and we need to just put efforts in the early years so that, okay, everything is ready and only a few modifications have to be done on every year basis. So also where CBME stands is reluctance with few, but ignorance with many. Okay, so we shall conquer that fear with just accepting that we need to do that. So these are a few things what I wanted to share. Thank you.
And
questions?
One or two questions.
Thank you, Vrinda, for the session. It was very enlightening. I have a couple of questions and maybe suggestions.
Yes, sir.
Not every medical school has Vrinda Bhatt to take care, number one. There are many teachers who are finding difficult to create linkers, or we also call as case vignettes. Is there a possibility that we use the Commons platform, at least for Karnataka, create a common platform and share the so-called linkers or case vignettes so that there will be some uniformity? My concern is in the days to come, when next exam, so-called exit exam going to come, it will be survival of the fittest.
Yes, sir.
Those graduates from those colleges who are passing exit exam, students will prefer that. Others will slowly perish.
Yes, sir.
In the private medical school, they could be compulsion or pressured by the management to teach CBME. I do not know the effect of government college because they are relaxed. The government, nothing will happen to
No,
us.
sir. I have in my study,
Yeah.
I had done a few colleges from Karnataka, Kerala, and sir, you will be surprised that they are doing it, sir.
Good.
Yes, sir. We have Ranju Ravindran, sir. He has given a positive reply. He was one of the responders for that. And he
Yes,
has
sir.
given,
Yes, madam. Thank you for the session. And
Yes.
as you said, we are actually trying to collaborate with all the colleges. As Dr. Harish also, he's also from Kerala. And we have a common WhatsApp platform also where we share material, especially for hospice.
Yes.
We have worked around 15 to 20 models which can be shared across the. No, it's up to the college whether they want to select it or do it in their own way.
Yes.
But still, as far as possible, you have strived to create a uniform platform.
Yes, or give them some aid
Right.
too. Sir, about the vignette that you said, sir, Rajiv Gandhi RGHS releases the course curriculum for every year. And in that, wherever the linkers are required, it is giving the linkers also, sir.
That's nice.
Yes, sir. So at least thanks to the BOS, Dr. Jagdish, Dr. Nagesh, you are also part of the BOS. So all those members of BOS, somebody else is also there. Yadu? You are Shankar, you are all the part, and they have made efforts to bring it forth, sir. Even the logbook and everything has been designed by them. So we should really thank the BOS. I think they require a big round of applause, especially the RGHS BOS for doing such a fantastic job, because most of the colleges will have no problem in simply following it. Sir, they have even told about the number of hours, how it can be taken, the objectives, everything. So it's a very good job. I think even our association can bring it forth for
Exactly.
the
Use this
benefit
platform so that all of us will be on the same platform.
at same platform. Like we brought out the text, record book, something on similar lines, we can do it. Yes. Maybe we can act together with Simla also to make it a South India kind of a thing. Yes, Nagesh.
No, actually, the linker cases has to be like prepared with all the subjects, not only forensic medicine. It is very easy to tell actually, okay, from Kamals you prepare and all those things, because we'll be having only idea about our forensic medicine. It has to be like, you have to discuss with medicine, especially over actually that subject comes like psychiatry, pharmacology. So over actually that subjects where actually we can integrate. So we have to talk to them. It is not one session. It takes at least 5 to 10 sessions. We have to sit together and you have to develop a case, and it has to be a continuous. When you want to implement in the second year, it should be at that level. Only that much information should be given. And when it goes to third year, you need to introduce little more about that particular. For example, medicine actually you want to introduce more regarding management and all those things. So that's why we need to talk to all the departments, and it has to be developed. It is a one-time this one. Okay, you have to, yeah. So then actually it becomes much easier. It's not like from Kamal side actually prepare. It becomes very difficult to we finding a lot of difficulty in university to bring out the curriculum. Now making interlinker case is a big challenge. Most probably you have to see another another 5 years. I think we may come out with some kind of solution for this. Yeah. Yes. Yeah. Yeah. In our college, actually, we have made a integration committee separately. We have made one chairperson for that, and we included at least two or three little youngsters to middle level faculty, because usually that higher faculty is little resistant to bring a change. So assistant professor to like associate professor, that kind of people were included. And we are like, just motivating them actually make one, bring one case, and along with that actually add information from that particular subject. Like that actually it is going on. Still like the last 1 year actually we are doing that, and we have achieved at least about 50% of that. I think it takes some more time to like complete that.
So last,
Nagesh, with regard to your suggestion, as agreed, as almost all the colleges are having the integration committees and all. As Dr. Vrinda rightly told, the main problem from clinicians is time is they are not having free time, they are busy, wards, rounds, etc. That is the major hurdle from clinician side for integration.
last words by Jagdish sir.
No, it's not last word. I want to put it, all the efforts they were complimenting, Vrinda was also complimenting, but unfortunately the system is not yet ready. All the good efforts, whatever we did, the university has asked right now to go 2 steps backwards and say that OSPI may not be possible to be implemented in the summative evaluation, which is starting in January. So in fact, we are meeting in the sidelines of this conference. So, all colleges are ready, but unfortunately university is not ready. So we are actually calling for the BOS meeting hurriedly today at the sidelines of this conference only. But with the permission of the organizing chairperson and the chairpersons, I'm asking one last question. We had proposed 8 exercises. Yeah, I got it. So those of you who want to share your views, please stay back in the evening after the 2 scientific sessions, so that though others are not the members, I would invite your suggestions for finalizing the thing. So that's all. Thank you.
Thank you, ma'am. Thank you, and I congratulate Dr. Vrinda Bhatt, madam, for this wonderful talk. We'll close the session here. Thank you, organizers, for giving this opportunity.
Thank you, esteemed chairpersons and respected speaker, for the knowledgeable insight on the topic. Now, I call upon our chairpersons to felicitate the speaker on our behalf. Now I call upon Dr. Venkatesh Malal to acknowledge the chairpersons for chairing the session.
Thank you, sir. With this, we come to today's end for the session. I'd like to inform that now we're going to have 2 parallel sessions happening. One for the PGs in the Annex Hall and the other one at, for the PGs in Sri Rajendra Auditorium in the very same auditorium, and the other one will be in the Annex Hall right beside the auditorium. Thank you. Before we begin, we'd like to ensure whether all the PGs and participants are present. Dr. Perumal, Dr. Divagar, Dr. K. Veerakumar, Dr. Rahul Panwar, Dr. Tejas, Dr. Shruti, Dr. Indu Ravikumar. The allotted time for each presenter is 6 minutes, followed by 2 minutes of discussion.
I would now like to invite our chairpersons for this session 1, that is Dr. Vijay Kumar AG, Professor, Adan Chunchungiri Institute of Medical Sciences, Mandya, and Dr. Rakesh M, Associate Professor, SS Institute of Medical Sciences and Research Center, Davangere. Now we hand over the session to our esteemed chairpersons.
So good afternoon, everybody. I welcome you all for PG oral presentation session. And without wasting much time, I would like to call the first presenter, Dr. Anand. Sorry. Dr. Perumal P.
A very good afternoon, everyone. I am Dr. Perumal, postgraduate student, Department of Forensic Medicine and Toxicology, Jawaharlal Nehru Medical College, Belagavi. Today, I am going to present maternal mortality, a case report. Introduction. Maternal mortality is the death of women while being pregnant or within 42 days of termination of pregnancy. Maternal mortality is an important index to assess health service, social progress, cultural and economical development in a nation. Forensic expert role is very important part in wider knowledge gathering process that can contribute to change in reducing the maternal mortality rates. Autopsy reports make recommendations for improving national obstetric practice, optimum quality of reports, and to determine the cause of maternal death. According to Indian sample registration system released by Registered Governor of India, maternal mortality ratio is 103 per 1 lakh live births during 2017 to 2019. These are the major cause of maternal deaths in India. Case detail: the deceased age 22 years and the date of autopsy 28/4/2022 and the period of survival 15 days after delivery. In nutshell, on April 13th, she delivered a male baby by LSCS for abnormal fetal presentation in a government hospital. After 4 days, she was apparently normal. And on 17th, she had abdominal distension, high-grade fever, loose stools. And then she referred to a private hospital and diagnosed as pelvic abscess and underwent exploratory laparotomy for abdominal distension. And she was in ICU for 6 days. On 26th, persistent abdominal distension present and started disorienting sensorium and agitated behavior. Then she referred to Jawaharlal Nehru Medical College. On 27th April, despite all resuscitative measures, patient could not revive and was declared dead at 4:15 p.m. External examination: stria gravidarum and linea alba present over lower abdomen. External injuries: surgically sutured wound which is inverted T-shape, vertical incision 10 cm in length, 5 cm below umbilicus, horizontal curved incision of 15 cm in length running along the lower end of vertical incision, 5 cm above the pubic symphysis. Internal examinations: all are intact. And the thorax: lungs, both lungs are intact and consolidated on consumption, pus with blood froth exudes on compression, and others are intact. Abdomen: kidneys intact and congested, and other organs were intact. In uterus, enlarged in size, contain 50 ml of greenish colored fluid. Endometrial cavity shows attached blood clots, and in fundus, surgical incision present. In histopathology, liver, centrifugal hepatocyte shows atrophy and necrosis and features of cholestasis present. And bilateral lungs, septate fungi with acute angle branching, which is mentioning and suggestive of bronchopneumonia. And uterus, uterine wall, hypertrophy of myometrium and congestion and edema. Up to this point, we had followed standard autopsy practices. And furthermore, we are advised to adhering Washington State Department of Health guidelines for maternal death autopsy. In this, we include case informations and which is enhance the normal routine autopsy reports and its accuracy. And it's very crucial for information collecting process. So we recommend autopsy surgeons should consider previously case details to be obtained before the autopsy procedure with the primary obstetrician. And here, infant status also included. If there any infant or fetal death is happened, we consider fetal autopsy also. And here includes care provider facility and clinical summaries and external examination specific to maternal mortality and internal which is specific to maternal mortality, and photographs, histology, toxicological, microbiological evidence are collected, and neuropathology opinion, cardiovascular and placental and obstetric pathology opinion to be obtained. And if there is no evidence of previous biochemical markers, we can obtain vitreous tumor. And based upon this, we obtain some key elements, which is in this case, postpartum hypernatremia present, which is a rare disorder, only few cases reported. And timely diagnosis of same and adequate corrections by oral and intravenous free waters is very important in this case. So it's not done in this case. And cause of death is due to septicemia as a result of post-surgical complications. And this paper presentation determines various factors and the utility of medical legal autopsies and autopsy records as a useful and adjoint data source for assignment of maternal deaths and illustrating the emerging trends. And Washington guidelines for maternal death autopsy is assist the forensic surgeon in focusing on particular issues of death related to pregnancy in order to optimize the autopsy procedure, report for clear identification of cause of death and any contributory factor. These are my references. Thank you.
Thank you, Dr. Perumal. The presentation is open for discussion.
Sir, because this is a maternal mortality, we in outside that surgery is done, sir. So we don't know whether it's medical negligence happened or not, and some relatives are give some medical negligence related puts. Sir. No, sir. As per protocol in our hospital, sir, all maternal mortality cases are under the medical legal only, sir.
And just to get offended, looking at the photo
Yes, sir.
of the scar on the dead body is part of the body photo is taken.
Yes, sir.
And the weight of the deceased person, 69 kg, to that added to that photo is not matching. Number one. Number two, whether the infection started within 42 days after delivery or the LACS,
Yes, sir.
or death occurred within that 42 days. I want clarification.
So, after 15 days, death occurred, sir. After LSCS done, after 15 days, death occurred, sir.
No, after 15 days.
Yes,
When the infection started?
Sir?
Infection started when? Post-operative period?
Sir, after 4 days, she was apparently normal, sir. After 4 days only, it started.
So within 15 days, she died.
Yes, sir. Within 50 days, sir.
So cause of death is exclusively separate from pregnancy related issues.
Yes, sir. I insist here that postpartum hyponatremia, which aggravates the sepsis, sir.
Aggravates.
Yes, sir.
How it is linked scientifically then? Just like diabetes.
That's I'm
Any clarifications in this regard from anybody? Is it necessary to make all maternal mortality as a medical legal case?
Sir, yes. To reduce.
No. In your hospital, you told it's a protocol.
Yes, sir.
If Prasanna sir or somebody is there, or Somshekar sir. No. Maharashtra government has made mandatorily all maternal deaths should be informed to the police wherever it occurs, whether hospital or otherwise also. But in Karnataka, that rule is not there. Unless that particular institute or the hospital makes that rules regulation, or unless the doctor treating feels that there is something fishy in that case and he can make MLC. Yeah, that's what.
Yes, sir.
If there's a causal connection between the surgery or a procedure
Yes,
and death, it has to be medical legal. Who will be accountable for the death, unnatural death? Infection is secondary to the intervention by the doctors. Doctors cannot go scot-free. I'm sorry. I beg to differ with you, sir.
I have a query. That is, whether there is any reference that postpartum hyponatremia will increase the infection.
Yes, sir, there is one article.
Was that study?
Sir?
Only this article, sir.
Yes, sir.
It's good that you should have seen in the discussion part that articles has to be mentioned and what was their result and conclusion.
I refer.
And what is your perspective regarding the medical negligence? You told that the body was brought to you as the relatives alleged that there is medical negligence. Now, after the autopsy and after perusing all the clinical case records, what is your present view regarding the medical negligence?
In this case?
Yeah, in this case.
Sir, actually, in this case, I posted that a rare condition postpartum hyponatremia, which is not diagnosed timely, sir. So that which aggravates the sepsis. Sir? No, sir. Because that's a medical condition, sir.
One just clarification. The fifth reference.
Yes.
What is that you have incorporated from that reference in your article?
Sir, in this, sir.
Fifth reference, what is the reference you have incorporated in your presentation?
No, sir. I actually, for organs, weight, those things.
I'm sorry.
Yes. Just I would like to know why the Washington guidelines were followed. Are there any Indian guidelines regarding the maternal mortality autopsy cases?
No, sir. It's okay, sir. I just, it's reduces the points.
Reduces the points means?
It improves our autopsy.
Yeah, as the autopsy is being conducted in India, you should follow the Indian guidelines, right?
Yes.
Thank you.
Sir, so we're getting shortage of time.
Yes. Thank you, sir.
Now I'll call upon Dr. Divagar K for the presentation.
7 minutes. Also, chairpersons, please note the time taken by the presenter was 6 minutes and 11 seconds.
Okay, Dr. K. Veerakumar.
Please come on the stage.
With the permission of the chair, sorry, I am intervening. It is only to convey that we have two sessions back to back, and considering the time limitations, I request all audience to be brief in their questions so that we can finish the presentations. Because to encourage all PGs, we have accommodated all submitted presentations. We have to ensure that they are presented from the platform. Humble request from organizing committee. Thank you.
Good afternoon to everyone. Myself, Dr. Veera Kumar, postgraduate from Government Chengalpattu Medical College, Tamil Nadu. I am here to present on a case report, an irrelevant type of death in de-addiction center. Asphyxia is a condition caused by interference with respiration due to lack of oxygen, due to which the organs and tissues are devoid of oxygen, causing unconsciousness and death. So the pressure effects of ligature over the neck, a tension of 2 kg on the ligature blocks the jugular veins, whereas the 5 kg blocks the carotids and 20 kg block the vertebral arteries, 15 kg blocks the trachea. Mechanism of death: asphyxia, venous congestion, both cerebral anemia, reflex vagal inhibition, fracture and dislocation of the cervical vertebra. So the brief history about the case: on one fine day, this last June, we received a case of 40 years old male dead body with the history of head banging over the walls in a de-addiction center. So external examination, the body was lying on its back, moderately built. The length and breadth has been mentioned. Hair distribution, color were black and white in color. Rigor mortis present all over the body. Postmortem hypostasis was found to be fixed, seen over the back of the body at the dependent areas except over the pressure points. Eyes congested, bluish discoloration of fingers, toenails were seen. There were no discharge found any of the orifices. External injuries: a laceration with reddish margins of size 3 cross 1.5 cross centimeter, bone depth seen over the center of forehead. During external examination, we also noticed a ligature mark over the front and sides of the neck. So, this is over the front and sides of the neck. So, which made us to shave the beard to look for any other significant findings. So, after shaving, we were able to find 2 incomplete, asymmetrical, oblique, parchmentized dark brown ligature aberrations with intervening vertical distance of 4.4 centimeter. These 2 ligature marks have been merged on the front of the left side, and posteriorly they merges at the occipital region. So, our length from the right mastoid and towards the left mastoid and chin and sternal notch have been depicted in this picture. So, on dissection, the soft tissues under the ligature mark were dry, pale, and glistening without any extravasation of blood. Iod was found to be intact. Thyroid and cricoid cartilages were found to be intact. Larynx and trachea intact. So, on dissection of head, scalp wall intact. Membranes and brain, edematous and surface vessel engorged, cut section congested. Cerebellum normal in size, congested. Ventricles, few mLs of straw color fluid is found. Base of skull intact. So, on dissection of chest, so you can able to, in the ribs intact, heart, multiple subepicardial and subendocardial petechial hemorrhages seen over the surface of the heart. So, no free fluid in the pleural cavity. Lungs, multiple subpleural petechial hemorrhages seen over the interlobar surface of both lungs. Cut section congested. A dissection of abdomen, all organs are congested. Bladder, 90 ml of urine, and pelvis and spinal cord intact. So, viscera was preserved and sent for a forensic science laboratory, Chennai. The report we arrived is negative, did not detect alcohol or any poisonous substance. Opinions to the cause of death: died of asphyxia due to constrictive force around the neck. Discussion: in this particular case, the history itself is irrelevant. It presented as a head banging of skull over the walls, but an incidental finding of ligature mark around the neck has changed the cause of the death itself. Till now, the investigation is under progress and we do not know the outcome of the case. Since there were no signs of struggle, homicide could be ruled out, as it is not possible to constrict the neck of a moderately built male who was not under intoxication or any other drugs. However, what we suspect is there may be head banging followed by commission of suicide by hanging. This particular case would have not been revealed by the authorities of the de-addiction center at Chengalpattu. The outcome of the case will come to limelight only with the investigation of the investigating officer. Thank you.
Now the podium is open for question and answer for maximum 2 minutes.
The term head banging is used in this case.
Yes, sir.
The term head banging.
Yes, sir.
Against the wall.
Yes, sir.
Is it before suspension in this case, or is it during suspension in this case?
Mostly before suspension, or it might be after hanging when the body is being get down. It might also occur in the perimortem.
You have described on dissection of before dissection of scalp only it is bone deep in your description.
Yes.
How can? You have described
yes, sir.
Before dissection of scalp itself, the contusion on the forehead, bone deep. You described that.
Yes, sir.
That is why this question. Whether this wound is caused before suspension or wound is caused during suspension, and you told lastly that it is caused while bringing down body also.
Might be, sir, but mostly before.
Can we use this might be in
Maybe,
our
sir.
report?
Because.
Then what made us to make this case as a different from others? And lastly, openness to cause of death, you have said compression over the neck. Is it not possible for us to say due to hanging, if not suicidal or homicidal hanging? Commonly, we give opinion in such cases, death due to asphyxia as a result of hanging. Commonly.
Can you go back to one slide before? Yeah, the references. You've taken 8 references.
Yes, sir.
Which of those are relevant there? None of them. Have you cited any of these references in your case?
I didn't mention, sir, but the definition and have been taken from Narayan Reddy, Dr. Narayan Reddy and O.P. Murthy, sir.
In the first 1 or 2 slides, you said asphyxia is death, right?
Yes, sir.
And last you have given cause of death. How do you explain that? You said mode of death in the first slide or second slide.
Yes, sir.
Right? Go back still. Still back. Still, yeah. Next. No, go back. Yeah, here. The term asphyxia indicates mode of dying rather than a cause of death. And in the end, you are saying cause of death. How do you justify this? Explain. Okay, I think after this, I'll make an observation. I don't want to go into the assessment.
You go to the injury slide where you have mentioned injuries. Laceration is 3-dimensional or 2-dimensional?
Laceration is 3-dimensional.
Bone deep means how much depth? Scalp layers are there, no?
Yes, sir. Approximately 0.5 centimeters.
No approximate.
Yes, sir. It's 0.5
No ifs and buts in forensic medicine. Look.
Thank you, sir.
Thank you, sir.
Now I call upon Dr. Rahul.
I think I just wanted a small observation. The title should convey the message of the contents. The previous one, title has no correlation, irrelevant or something. There should be a scientific title should have some inputs into the case. Otherwise, several irrelevant data was given in this case, which is not required. like measuring the hair and all those things, length, which is not relevant. That was relevant.
Okay, please go ahead.
Good afternoon, all the faculty members, all seniors, and my colleagues. Today, I'm going to present my clinical case, Perthes syndrome, a clinical and forensic narrative. Introduction: Perthes syndrome is a clinical phenomenon typically developed following thoracoabdominal compression. It is also known as traumatic asphyxia, crush asphyxia, or Oliver syndrome. It consists of triad of cervico-facial cyanosis, bilateral subconjunctival hemorrhages, cutaneous petechial hemorrhages. Commonly seen in case of stampede, RTA, industrial and farming accidents, Perthes syndrome classical findings are rarely encountered on autopsy as a result of favorable prognosis after appropriate clinical management. Case. So, a patient, 29-year-old patient present with alleged history of topple tractal while driving. Patient was referred from PSC to AIMS emergency with polytrauma. The patient was conscious, intubated, and had a poor GCS of 4/15. Medical legal examination by a forensic resident was done on the same day. External finding. On examination, the findings are superficial to deep burn with charring, blackening, and peeling of skin present obliquely, extending right side of face, neck, below mandible to inner aspect of left arm, involving the right side of neck, right angle of mandible to 4 cm, right lateral to sternal notch. It is also like extending to the left side of chest, 10 cm below the middle 1/3 of the clavicle, involving left nipple, axillary region, and extending up to the middle 1/3 of arm. And margins are erythematous. Here is the front view of the injuries. After this, we found like a very classical sign of traumatic asphyxia or Perthes syndrome is Bresser's sign. So we can see the pale area surrounding by the petechial hemorrhages present over the chest. Here is another sign like subconjunctival hemorrhages and congestion of the face is also present. This after we just like follow up the case and see the timeline of the lab test profile. So on the day of occurrence of the incidents, the AST, ALT, LDH, and creatinine phosphokinase is increased like very highly. And after the second day, it is just half of the first day. And after like 6 to 10 days, it is just in the normal range. Chest X-ray. So chest X-ray of the patient are just we can see on right side 2 to 6 rib fracture, non-displaced, and on the left side 2 and 6 rib fracture and fracture of the middle 1/3 of the clavicle of left side. Here is the CACT chest finding, which confirm the finding of X-ray non-displaced fracture of right 2 to 6 rib along with mid-clavicular line, fracture lateral part of left 4, 6, 7 rib, and 2 parts of fracture of left 5th rib, non-displaced fracture of medial 1/3 of left clavicle, and additional findings are bilateral minimal pneumothorax, pneumotocele with air fluid contusion over the anterior segment of left upper lobe, which is correspond with the injury number 2, ground glass appearance in apex of the left upper lobe, atelectic band present over the superior segment of the left upper lobe, superior and posterior segment of left lower lobe, and posterior segment of right lower lobe. CVS and GI system was unremarkable. Patient interview. So after follow-up, like after one week, later on after 1 week during the patient's follow-up interview, the patient confirmed that the tractor had toppled over him. He was pinned between the fuel tank and the ground, and the heated silencer pipe was against his neck and chest, which explained the burn injuries which is present over the his chest and neck. That scene construction which is done by the patient's follow-up interview and our observation, which is we draw discussion. The case represents the classical triad seen in case of traumatic asphyxia. The burn injuries were not correlated with the history until the detailed follow-up history was available. The biochemical parameter like AST, ALT, CK, LDH also play an important role in diagnosis when the history is ambiguous and where the classical signs are not present. Bresser's sign provide a readily observable and easy recordable sign of traumatic asphyxia due to the chest compression. Bilateral periorbital swelling, chemosis, and mild exophthalmos are the important supportive findings or signs. Conclusion. Perthes syndrome is a less reported clinically as a common finding are not recognized because of the multiple injury or when the presentation is not classical. It should always be kept in mind in such patients, especially when the injury involves the blood trauma to the chest. Often unconscious patient with low GCS steered the case toward a head injury many times. Cerebral edema is a shared finding of both head injury and traumatic asphyxia. That's why many times it is deviate toward the RTA or head injury. Further follow-up and collaboration with the investigation team and history from rescue is also important to diagnose the Perthes syndrome and traumatic asphyxia cases. A biochemical profile evaluation of the patient is crucial in diagnosis and management when classical signs are not present. Management include early recognition, general supportive measures, and organ-specific treatment. These are the references. Thank you.
Thank you, Rahul. The session is open for discussion. Yes.
You told that biochemical parameters play a vital role in diagnosing the condition, right? What is the relationship between the biochemical parameters and the Perthes syndrome?
Sir, in Perthes syndrome, like biomedical parameters are increased because of the crush syndrome. Like in crush syndrome, like myoglobin are increased because of the muscle injury. So if like cardinal signs or classical signs are not present, like laser signs, so we can easily recognize and diagnose that it is due to the compression of the chest.
If that is the case, was there a outcome of renal failure in the form of ATN?
Yes, sir.
You not mention renal parameters. Did you mention renal parameters?
No, sir. Because
You're talking about crush syndrome. We expect crush
Yes,
syndrome, acute tubular necrosis,
Yes,
and renal parameters. You have not mentioned a single renal parameter. How do you justify that?
Sir, because in this patient, sir, these parameters are normal, like not in that much high. But in previous some literatures, like ALT, AST, liver parameters, and like cardiac parameters are also very high. Yes, sir. Sorry.
So, in this case, do you want to send something for histopathological examination?
So it is not a autopsy case, so we can send some
clinical case. Okay, fine.
clinical case. Also, surface area, like on neck surface, it is 14 cross 6 centimeter, and over the chest and nipple and middle 1/3 of arm, it is cross 20 cross 9 centimeters.
Whether this person died due to consequences of signs? No,
Not that.
it's not that. Okay, notice. Now, whether all these signs were due to lack of oxygen during
Yes,
compression or due to chest injuries?
Sir, it is like due to compression. Due to the compression, like patient is deep breath, and the patient is deep breath, and because of the fear response, the superior vena cava pressure is increased. So due to the superior vena cava pressure increase, the backflow of venous.
Thank you, sir.
So it is due to the backflow of the venous system. So that was rupture of the capillaries.
Thank you, Rahul. We'll move on to the next presenter, Dr. Tejas.
Good afternoon, everyone. I'm Dr. Tejas Kumar, first year postgraduate from Bangalore Medical College. Today, I'm going to talk about iliac artery puncture by a bull-gore injury under the guidance of Dr. Suresh sir, Associate Professor, and Dr. Venkat sir, HOD from the Department of Forensic Medicine. Coming to the introduction, bull-gore injuries are the common accidents in rural India where people make the run by rearing the livestock. The range of injuries varies from the abdomen, chest and scrotal region. Bull-gore injuries are very frequent, especially in cases of strong bullfighting tradition and at National Reserve Forests. Let us come to the classification. Sideways thrust, where the horn thrusts the body tangentially, which causes only contusions. Jab, where the injury is caused by the tip of the horn. And misleading wound, where there is an orifice of the entrance that is far from the core injury. and its associated lesions can coexist, and the goring, which is deep wound that affects fascia and the muscle. Coming to the history, a 35-year age farmer came with alleged history of bulgur injury to lower abdomen near his resistance on 11 at 12:30. The patient brought to the district hospital and conservative management done. Then the patient referred to the Victoria Hospital for the further managements, and patient died after 1 day of the treatment. And as it is a treated case, we could not get the original injury picture. And external findings: horizontally placed surgically stapled wound measuring 8 centimeters in length with sutures in situ present over the front of lower abdomen, and vertically stapled wound measuring 19 centimeters with intact staples in front of the abdomen, and surgically sutured wound measuring 2.1 centimeter present over left flank. And on the removal of sutures and the underlying subcutaneous tissues, muscles are sutured with intact suture material. On further dissection, subcutaneous tissues and muscle shows diffuse blood extravasation, as you can see in this picture. Internal findings: all the internal organs were pale. Both the pleural cavity and peritoneal cavity fills with dark fluid. Lungs were consolidated and covered with thin layer of pus. Momentum thickening present with blood extravasation. And coils of intestine adherent to the thin layer of pus at places. And coils of ileum shows surgically sutured wound with 3 sutures measuring 5 centimeters in length. And blood extravasation also seen on perinephric region and left lower abdominal muscles with blood clots weighing 500 grams. On dissection of left common iliac artery, there is a punctured wound measuring 0.3 centimeter across 0.2 centimeters, which is situated 1.6 centimeter from the origin. And there are multiple tears present over the external iliac artery, inner surface of external iliac artery. This is the picture where you can see the punctured wound. On the CT scan, we observed pelvic hematoma, pneumoperitoneum, and findings suggestive of bowel injuries. As we all know the anatomy of the common iliac artery, from the abdominal aorta, it divides into left and right common iliac artery. Injury has happened at left common iliac artery. In a study of injuries in Nazimal husbandry, concluded that bulgur injuries are the most common ones. It causes contusions, laceration, and penetrating injuries. In recent case report, stray cattle are quite rampant in India and Africa. They wander in the cities, block the traffics, and defecate, and most importantly, attack the people. At times to gore people to death. Conclusion: injuries caused by animals, especially bulgur, could be life-threatening as well as disability due to site of involvement. Early intervention and trauma can be life-saving. Management of bulgur injury is a challenging task for the doctors who need eye suspension for the diagnosis of the condition and its management. Cause of death is due to shock and hemorrhage as a result of penetrating injury sustained to the abdomen. These are my references. Thank you.
Thank you, Tejas. The session is open for questions.
You said adhesions were in the abdomen in some pus. How many days person survived?
1 day, sir.
Do you expect pus in 1 day?
Sir, injuries we observed, we dissected common iliac artery, sir. It got punctured wound, and that at place it is, I think it is uncommon, sir.
What makes you feel it is uncommon? Have you done a series or review of literature to see it is an uncommon site?
Thank you, sir. Thank you, Tejas. Thank you, sir. I would like to call upon the next speaker, Dr. Shruti MK.
Good afternoon, one and all. Greetings from Department of Forensic Medicine and Toxicology, BMCRI. I am Dr. Shruti MK, first year postgraduate student. Today presenting a case of ruptured thoracic aortic aneurysm under the guidance of S. Venkat Raghava, Professor and Head, Department of Forensic Medicine, BMCRI. Coming to the introduction, sudden or unexpected death are deaths which occur within 24 hours of onset of symptom in an individual who is not suffering from any disease, injury, or poisoning. Though the literature says the period may vary from 1 to 6 hours, only natural deaths are considered here and no age is exempted, and it accounts for nearly 10% of all the deaths. Coming to the case details, on 22nd of October this year, a 42-year-old male goes to his bathroom around 2 p.m. in his residence and collapses suddenly and was brought dead to the hospital. MLC was made and the postmortem was conducted the next day. Coming to the autopsy findings, on external examination, he was a light brown complexion male of 165 centimeters length, moderately built and nourished. Rigor mortis well established. Faint postmortem staining was noted over the back, and no demonstrable external injuries were noted. Coming to internal examination, scalp, skull were intact and the brain was pale. And opening the thoracic cavity, blood clots were noted around the heart, and around 550 grams of clots were removed. And thoracic aorta behind and below the heart was enlarged for the length of 13 centimeters and with the maximum width of 9 centimeters. And a tear of 1.5 centimeter and 0.8 centimeter was noted in the wall, which can be noticed nicely in this picture. The heart weighed around 280 grams, pericardium was intact, right ventricle wall was 0.5 centimeter thick, left ventricle wall was 1.4 centimeter thick, coronaries were thickened, and the atheromatous plaques were noted in aorta and the walls. The lungs were pale and edematous, cut section exuded froth with minimal blood. Stomach contained around 100 grams of partially digested food particles, no unusual smell, mucosa was normal, liver fatty changes were noted, and the kidneys were pale. Relevant history elicited later showed that he was a security guard with a high stress job, chronic smoker, and hypertensive with irregular medication. So cause of death was given in this case as death is due to shock and hemorrhage as a result of ruptured thoracic aortic aneurysm, natural death. Coming to the discussion part, the most common system involved in sudden unexpected death is cardiovascular system with incidence of 45 to 50%, and around 80% of that cases are due to coronary artery disease. Other causes include aortic dissection, cardiomyopathies, coronary artery anomalies, conduction disorders. Aneurysm comes from the Greek term aneurysma, which means dilatation. It is outward bulging caused by the localized weakness in the blood vessel wall, and arterial aneurysm is more common than venous. In arterial, it is commonly seen in aorta, subclavian arteries, circle of Willis, popliteal artery, and the rate of increase in the size of aneurysm varies from person to person. Around 50% increase is considered significant. Aneurysms can be congenital or can form later in the life. Common causes include infection, inflammation, injury, or structural changes. Risk factors include atherosclerosis, aging, stress, smoking, family history, genetic disorders. And it caused around 10,000 deaths in United States in 2018. It has a male predominance, and it is more common in male about 40 years of age. However, the existing aneurysm can rupture in a smaller size in females. Coming to the true aneurysm, it involves all the three layers, that is tunica, intima, media, and adventitia. Compared to that pseudoaneurysm, there is a collection of blood leaking outside but confined by the surrounding tissue, generally seen following the trauma to the vessel. True aneurysm can be fusiform, that is spindle shaped, seen in aorta or the iliac arteries, or saccular or berry shaped, spherical, with a neck connecting the aneurysm to the blood vessel, seen generally in circle of Willis. Aortic aneurysm, the location can be thoracic, abdominal, or thoraco-abdominal. Abdominal is the most common incidental finding. Aneurysm development, they can increase slowly in size, leading to thinning of the blood vessel. The thrombosis can occur, which can lead to embolism, or it can lead to dissection, that is tearing of tunica intima and the blood extravasation into the tunica media, or direct rupture. The notable people affected with the aneurysm include Joe Biden, current US president, who underwent surgery, and Chinese leader Xi Jinping, who is undergoing treatment, medical treatment. People who died due to aneurysm include Albert Einstein and Lucille Bell, US actress. Recommendations: US Preventive Service recommends any person with a history of smoking above 65 years of age to undergo a screening ultrasound of abdomen for abdominal aneurysms. Similar screening methods should be adopted to suit the Indian settings. These are my references. Thank you.
Thank you. The session is open for questions.
Three questions if permitted. Number one, the cause of death is based on autopsy findings or clinical study?
Sir,
Cause of death is shock and autopsy finding?
No, sir.
Yeah, thank you. Number two, what is the type of aneurysm in this case?
Thoracic aneurysm, sir.
No, I'm not this.
Fusiform, sir.
Yeah.
Fusiform.
And can you go to the references, please, to the back?
Yes, sir.
Which of these reference sites the presidents or premiers of two big countries?
The Wikipedia shows, sir.
Sorry?
Wikipedia. It was found in Wikipedia.
Wikipedia. Okay,
Yes.
thank you.
No, sir.
To know the cause of aneurysm.
Yes, sir. We didn't send it for histopathology, sir.
Yeah, and what a question, sir. Okay. In the findings that 550 grams of blood clot is
Yes, sir.
present.
We paid it later, sir.
Yeah, what is it meant of ml? If you want to convert that into ml,
Sir, 1 gram of clot is equivalent to 2.5 ml blood, sir.
it's 5 ml of blood.
Right. Okay.
Yes, now.
Thank you.
That was my question. I thought I was asking that. You said that coronaries were thickened.
Yes, sir.
Were they patent?
Yes, sir. They were patent, sir.
Was the patency seen?
Yes, sir. They were. It was less than 50%, sir.
How that was sectioned?
We did inflow method and we did the sectioning ourselves, sir.
At autopsy, how
Yes,
that
sir.
was seen? Patency of coronaries.
We did.
Yeah, you did, we believe. We want to know how you did, that's all. Okay, fine. That's all from my side.
Thank you, sir. Now I would like to call upon the next speaker, the next presenter, Dr. Indu Ravi Kumar.
Good evening. I'm Dr. Indu Ravi Kumar, first year postgraduate, Department of Forensic Medicine and Toxicology, Bangalore Medical College and Research Institute. On this auspicious day, November 25th, International Day for the Elimination of Violence Against Women, I'm hereby standing here for the presentation on the topic Intimate Partner Violence, a case report, under the guidance of Dr. C.N. Sumangala Ma'am, Professor, Dr. S. Venkatrakava, HOD and Professor, BMCRI. International Day for the Elimination of Violence Against Women. This year's campaign, Unite Activism to End Violence Against Women and Girls, is focusing on four main things. First one, intimate partner violence. Next, sexual violence and harassment, human trafficking, and child marriage. The color orange is used to represent a brighter future free from violence against women. Let me just mention two current cases. First one is the Shraddha case. After was accused of smothering his live-in partner, Shraddha, and later cutting her into 35 pieces, storing in his refrigerator and later dumping them away in nearby areas over a course of 18 days in May 2022. A man in Madhya Pradesh, Jabalpur, shot a video as he slit the throat of his girlfriend, whom he called unfaithful, and posted the video on the Instagram profile later. Introduction. Intimate partner violence is a crime encompassing physical, physiological, financial, emotional, sexual abuse by a current or a former partner. Love affairs and illicit relationship accounted as many as 3031 cases of murder across the country as per the 2019 reports. WHO 2012 defined it as any behavior within an intimate relationship that causes physical, physiological, or sexual harm to those in relationship, including the act of physical and sexual violence, psychological abuse, and even controlling behaviors. The term intimate partner indicates that the violence can be perpetuated by both men and women, regardless of the age, marital status, or sexual orientation. Now, coming to the case report, dead body of a 45-year-old lady was brought for autopsy by the police. Initially, as per the police information given, she was a this middle-aged woman. She took a house for rent about 20 to 25 days ago with a man whom she introduced to the house owner and as well as to the neighbors as her husband. On further inquiry, the police informed that she was a widow and she was living with her 23-year-old lover, and there were multiple witnesses of them fighting on multiple occasions. These were the images from the crime scene. On external examination, multiple abrasions, including nail scratches, were present over the front and sides of neck, over an area of 16 centimeter and 8 centimeter. The neck is diffusely swollen. Multiple abrasions were seen at places over left and right side of the face. Vertically placed laceration measuring 1.5 centimeter and 0.8 centimeter and 4 centimeter into 1 centimeter bone deep were present over the front of forehead on its right side and left side. Laceration were present on the middle 1/3 of the inner aspect of lower lip and upper lip. Both the lips were swollen. Multiple contusions were present over the front of chest over an area of 37 centimeter into 20 centimeter. Contusions were present over the back, especially right scapular region. Multiple contusions were seen on the front and the medial aspect of the right and the left lower limb, including the dorsum of foot. Coming to the age of injuries, abrasions were bright red to reddish brown color. Contusions were red and blue in color, which showed there were new as well as old injuries. All injuries are antemortem in nature. On internal examination, lung gross examination showed petechial hemorrhages. On neck dissection, the underlying muscles shows blood extravasation diffusely on either sides of the neck. Thyroid gland showed blood extravasation. Hyoid bone was fractured along the midline. The fractured ends showed blood extravasation. On reflection of the scalp shows blood extravasation over the frontotemporoparietal region on both sides. Both the temporalis muscles are contused. Brain was pale and edematous. Coming to the cause of death, there were multiple injuries sustained and signs of asphyxia was present. Since death due to asphyxia is imminent, the death was due to asphyxia as a result of compression of neck. Discussion. IPV or intimate partner violence is a serious and widely prevalent problem which is usually under-recognized. The problem is compounded by various cultural, political, legal, and economic factors. Substance abuse, especially alcohol, is closely related to the instance of IPV. Protection of Women from Domestic Violence Act 2005. It is an act of the Parliament of India enacted to protect women from domestic violence. It was brought into force by the Indian government and Ministry of Women and Child Development, actually implemented in 1993, and later amendment was done on 26 October 2006. The Act provides a definition of domestic violence for the first time in Indian law, with this definition being broad and including not only physical violence, but also other forms of violence such as emotional, verbal, sexual, and psychological abuse. Primarily meant to provide protection to the wife or female live-in partners from the domestic violence from the hands of husband or male live-in partner or his relatives. The law also extends its protection to the women living in the same household, such as sister, widow, or mothers. Coming to the laws related to live-in relationships, Article 21 of Indian Constitution safeguards the basic right to life and personal liberty. It includes the right to cohabit without interruption. As per the 2018 reports, the states with most crime of passion were seen in Uttar Pradesh, Bihar, and Tamil Nadu. United Nations Chief Antonio Guterres said every 11 minutes, a woman or a girl is killed by an intimate partner or a family member, calling violence against women the most pervasive human rights violation in the world. These are the references. Thank you.
Now the session is open for question and answers.
The injury description, can you go to that? You mentioned about the age of the injuries.
Yes, sir.
What's the age of the injury? Because you mentioned age. You only describe the findings. You not specify the age of the injuries.
Okay, sir. Bright red and reddish brown were.
No, I'm asking you should. If you're putting age, you have to mention what is the age.
Okay, sir.
Can you go to the pictures? Yeah. None of the pictures have a evidence that this is the case you have done. None of the, I repeat the question. Explain why, how do you say these are your case reports? I said these are textbook pictures or somebody else's pictures. What is evidence that they belong to you?
How did you appreciate a fracture of hyoid bone in midline?
Sir, the hyoid bone was taken out and we saw also a fracture line in the midline.
How can it fracture physiological, at least morphological structure of the bone for that given age? The body of the hyoid bone fracture in the midline.
So if it was a manual strangulation and anteroposterior.
I am just questioning fracture of bone in midline.
No, sir.
It can fracture, but how it could have happened? Midline, in midline.
Anterior compression of neck.
I just wanted to know what type of dissection was done in the neck here to appreciate fracture, hyoid bone, and all those observations. What type of dissection was done on the neck? Fine, thank you.
Thank you all. With this presentation, I'd like to conclude the session 1 of PG presentation. And I'd like to thank the JSS team for giving me this opportunity. Thank you all.
Thank you, sir. Thank you to all. I would like to invite Dr. Jagadish Rao to felicitate our chairpersons. Now we have a 10-minute tea break. The tea and biscuits are served outside.
Naveen Kumar, Dr. Kumar Mukund, Dr. Fatima Fahmi Shirin, Dr. Fatima, Dr. Jyoti S, Dr. Chaina Pati, I'm so sorry, Dr. UP Hemant Reddy. Kindly occupy the front rows, please. I would now like to invite our chairpersons for our session 2. That is Dr. Yadakul S, Associate Professor and Deputy Medical Superintendent, AIMS Hyderabad, and Dr. Shiv Kumar P, Assistant Professor, Jipmur Karakal, Puducherry. This is a poster presentation and the timing guidelines are 4 minutes plus 2 minutes. I would like to give the session to the chairpersons.
Thank you. For the session 2, I would like to call upon the first presenter, Dr. M.A.S. Ananthan. His title is Fatal Intimate Partner Violence, a Case Report.
Good evening to all, respected chairpersons, teachers and all delegates. Myself, Dr. M.A.S. Ananthan, under the guidance of my teachers, will be presenting a poster titled Fatal Intimate Partner Violence, a Case Report. Let's start the presentation with a famous quote by Martin Luther King Jr., where he states, "Injustice anywhere is a threat to justice everywhere." Gender-based violence has been acknowledged as a violation of basic human rights. And this has led to many deaths, with a recent example of the Shraddha Walker case. Here we present a case of a 36-year-old female, a housewife, who was found dead in her bedroom. And subsequently, the case was booked under section 498A 302 34 IPC against the husband. Autopsy revealed multiple abrasions of her left arm, left forearm, and right lower leg in varying stages of healing. Multiple contusions were present over the back and also over the left flank. There was internal contusion over the left flank with fracture of left side 6th, 7th, and 8th ribs with splenic rupture. Cause of death was opined that the deceased died as a result of hemorrhage due to splenic rupture as a result of blunt force trauma. The pattern of injuries were suggestive of repeated physical trauma. According to National Family Health Survey 5, 2019 to 21, the most common type of spousal violence is physical violence, which is amounting to 28%, followed by emotional violence, amounting to 14%. Now we shall see some questions which was put forward by the defense counsel during the cross-examination. The defense counsel was basically trying to emphasize on the fact that the injuries on the body and subsequent fracture, which was mentioned in the report, was due to self-fall. Doctor commented that the injuries need to be interpreted collectively, that is as a whole, rather than as single injuries, since the injuries are there on multiple sides of the body and they are at varying stages of healing. The defense counsel went on further and added that since there are no defense injuries, a physical assault has not occurred. The doctor commented that absence of physical injuries does not rule out an assault. Seeing that the opinion of the expert witness is not going in any favor of the accused, the defense counsel stated that unlike an expert witness, an ordinary man or a layman wouldn't have the knowledge that an injury over the back or the left flank could cause death, thereby implying that the accused had no intention to cause death. To this question, the doctor refused to comment. To conclude, I would like to state that dealing with this stigmatized topic in an open and supportive way is a prerequisite to identify victims of domestic violence in routine clinical practice. It also has to be kept in mind that both males and females can be a victim in intimate partner violence. Nationwide special counseling and support networks and shelters for victims of intimate partner violence could be a valuable adjunct to medical care. Thank you.
Thank you, Dr. Ananthan. The forum is open for questions.
Since we're familiar with this term, battered baby and a battered spouse syndrome, how is this different from that?
The intimate partner basically defines two people living together and who are either physically or emotionally intimate to each other.
This is spouse, no? Spousal violence.
Spousal.
Yeah. Battered wife or a battered husband or a battered child, also intimate relation, no?
Intimate relation.
But this new term coined, what is the source of reference for coining this new term? Source of reference for coining this new term, intimate partner.
It is first at all. United Nations rights for women, they have also first coined it, and later on in protection against women against domestic abuse in India also the act was there.
Any references? There's no references in your article.
No, sir. It is in the screen. References.
How many references?
Cut off.
Cut off.
Yes.
If they were really intimate, there would not have been violence.
You can't see us.
Other reference, because you're not. Present full screen, just wanted to know. What is the okay. United Nations National Family Health Survey? Okay, can you go to the citation of this in your text? Where have been cited? Yeah. Second one. Okay, thank you.
Thank you, sir. We'll move on to the next speaker.
Thank you.
Next presenter is Dr. M. Naveen Kumar. His title is Plethora of False Medical Knowledge Occurs in Current Scenario.
A pleasant evening to one and all present here. Plethora of false medical knowledge is indeed occurs in the current scenario because all these deaths are being buried by the media and the society, and the lame non-medical negligence cases are being boosted up. So I have picked up one such cases to be presented in this August forum. A 35-year-old woman who was conceived for the third time, and she was 5 months amenorrheic period, she had an accidental fall at her residence, following which she spontaneously expelled a non-viable fetus. The fetus was buried as such by her husband in the backyard, and the placenta was not relieved. An advice was given by the neighborhood lady suggesting that the placenta would take 1 day to come out. So you can wait and you no need to get any medical references. So seeking that, the lady stayed back at her home, and 22 hours after the delivery, after this episode, the lady collapsed. So very well, you can see in the autopsy, the cord is lying outside the vagina for about 14 centimeters. The uterus is pale. See, the uterus has not contracted. It has measured 36 cross 18 cross 8 centimeter, and the cut section, you can very well appreciate the placenta, which is adherent inside the uterine cavity. So cause of death is evident. It is due to atonic uterus and retained placenta. So as the discussion progresses, according to the National Family Health Survey, they say that why the patient or the lady are not going to a medical center. They list out the common causes. Women think it was not necessary, 28%. Family members stopped the girl or the lady, which accounts for 19, and health center was too far, 17, and the cost is too much, it amounts to 15%. And my title adds up to this cost. So institutional deliveries, well, they have increased in numbers from 79 to 89%, but this case is again a stigmata to this number. And as I suggested, PPH, postpartum hemorrhage, is indeed a major cause of maternal mortality, and the uterine atony is one of the major risk factors here. What I want to put out in this forum, as forensic surgeons, whatever cases as such, not only obstetrics, we have orthopedic cases going under native treatment, brought it to our official capacity. We have to put them in the current forum, or we can maintain data for it so that it can be represented in the media or for discussion later. And governments shall take stringent action on such social media platform who are giving false information and the acts of delivery. And every pregnant woman should have a knowledge of the process of delivery, how the process occurs, how the placenta is being delivered, and the need of medical supervision is also to be intimated and instructed in a very cautious manner. And these are my references. I thank everyone for this opportunity.
The forum is open for questions. No, I just wanted to know a couple of clarifications.
Yes.
Which department do you belong to?
I belong to the Department of Forensic Medicine.
It's not because your first reference OBG. I was just looking. Nowhere it's mentioned Department of Forensic Medicine.
So symbolically, you mentioned.
Where?
Yes, of course.
Where is that? I'm sorry, that's not your logo.
Sorry.
It's not forensic logo.
Yes.
Okay. Those Mudliar and Menon, what is the reference you have used and what is cited there?
Sorry that I have not cited, but the
if you're not
reference,
cited,
yes,
you will not put it.
Okay, sir. I failed to cite the numbers.
Okay. What is the first picture, left upper quadrant? What is the right thing on the picture?
This one, sir.
Left side.
This one, sir.
Picture, first picture.
This one.
Yeah.
So the umbilical cord, sir, it has not been ligated. It is prolapsed via the vaginal canal and seen outside.
And second conclusion, government shall take stringent action on social media platforms which provide lethal and false facts. Can you explain those two terms? Lethal and false facts.
So lethal fact is that the lady from the social media platform, she has imbibed a knowledge saying that they can wait for 1 day for the placenta and the products of consumption to expel out. So that is something lethal. And the false fact, sir. Okay, so grammatically it's contradictory. Okay. It's lethal to I meant it is lethal to the victim.
Hello, good presentation. Little beyond what is presented, because you said it is a non-viable fetus.
Yes.
Did you examine the fetus and what made you to say it is non-viable?
Actually, the lady is 5-month amenorrheic.
It is a history.
History,
but
sir.
you said the fetus was buried back in the backyard. Was that removed and examined?
No, sir. We instructed the IO to exhume under 318 IPC. So because birth has been concealed, but the IO didn't pay heed to us.
So to
because-
call it as non-viable, it is only history.
Yes, sir. It is
But,
history.
yeah, it should
According
have
to
been
our
little
standards, according to Indian standard, 20 weeks of gestation.
But we don't know.
Yes, sir, we
because
don't
that is
know.
history.
We do not know, sir. Yes.
To call it as non-viable fetus, it should have been little more authentic to present in a conference. That's what I believe.
Sure, sir.
Thank you.
Yes, thank you.
According to India, something you said 20 weeks viable. Can you please give a reference what you're talking about? Complete that statement and reference.
Sir, from OBG Mudaliar and a forensic book, according to Indian standards, we presume that a baby which crosses 28 weeks of gestation, it is viable. But whereas in other we too have cases, even a 20-week baby has been restated and maintained.
You're mixing up issues. Okay, thank you.
Thank you, sir.
Thank you, sir. We'll move to the next presenter, Dr. Kumar Mukund. His title is Suicide by a Rare Poison, a Case Report.
Good evening, everyone. I am Dr. Kumar Mukund, final year postgraduate, Bangalore Medical College. First of all, I thank KAMLSCON-2022 for giving me an opportunity to present on this stage. Today, I am going to present a poster, and my title is Suicide by a Rare Poison, a Case Report, under the guidance of Dr. Suresh sir and Dr. Asphyxia sir. Suicide is one of the common manners of death among youngsters. There are various methods for committing suicides, and poisoning is one of the commonest and easiest measures. Organophosphorus compound, rodenticides, and sedatives are frequently used. Selection of fruits of toxic plant to commit suicide is rare because of lack of adequate knowledge about toxicity and fatal dose. Moving to case report, a 22-year-old female had committed suicide by consuming crushed fruit of Cerbera theracia. The photographs of these fruits and the flowers had been recovered from her phone's gallery. This case is being presented here to highlight the toxicity and post-mortem appearances of this plant. Coming to external injury, in external injury, there is no demonstrable injury present over the body. In internal examination, brain is congested, lungs shows hemorrhage, heart shows epicardial hemorrhage and subendocardial hemorrhages. Stomach shows patchy congestions. Other organs like kidneys are congested. This disease was treated for 10 hours, and the blood and visa has been sent for chemical analysis. Because of death, my cause of death is reserved pending for chemical analysis report. In third column, first row, these photographs are recovered from phone gallery of the disease. Coming to the discussion, Cerebria theracia, also known as yellow oleander, tiger apple or bastard oleander, it is a cardiotoxic. All parts of the Cerebria theracia are toxic. It has a flower, yellow colored flower, funnel shape or bell shape, lanceolate or pointed leaves with dark green upper surface and light green inner surface, under surface. Fruits are diamond in shape or clam shape, which contain kernel seeds, which is more toxic. And each part of the Cerebria theracia plant produce milky juice or sap on plugging or cutting. As it is a cardiotoxic, it contains cardioglycosides like peruroside, ruboside, thebatin A, nerifolin, then cereberin and thebatin B. Fatal dose 8 to 10 seeds or 15 to 20 gram of roots. Coming to mode of action, it's shows a digoxin-like effect by inhibiting sodium-potassium ATPase channel, which lead to decrease the action potential and lead to hypertension and hyperkalemia. Effects on hearts like subendocardial and perivascular hemorrhage with focal myocardial edema. Earlier, Cerebria theracia used as a local ailment for skin disease and abortifacient by ruler fork. Even cytotoxic agent is going in research for cancer treatment nowadays, but it is not come in human trial till now. My reference is Comprehensive Medical Toxicology, third edition will be sir. Thank you.
Thank you, Dr. Kumar Mukund. The forum is open for questions.
No, sir, this case is treated already for 10 hours.
Heart was sent for autopsy is the question.
No, sir, it's not sent.
Cause of death you have given, not given.
Sir, we are waiting for chemical analysis report.
Do you expect any report?
Sir, it is already treated for 10 hours.
No, no. Are you expecting anything positive? Yes or no?
Yes, sir.
Okay. What is a rare poison? Can you define rare poison?
Sir, normally the poison which is not used normally.
Who says? Is your
No, sir, like less
your
than,
definition?
No, sir, less than 3.
No, when you're putting in a title of an article, there should be a reference to call a rare poison.
Because, sir, the lack of knowledge of toxic plant.
To whom?
To the normal people is not adequate.
This is a very common poison in South India. Very common. If you say rare poison, it's a disagreement. No, Pondicherry Kadala. Do you know what is Bish regime? Have you heard of that or no? Oh. This is not a rare poison, and if you define rare poison, you must define based on scientific evidence. It may be rare in Bangalore. It is not rare in South India. In fact,
in Manipal and all, we have seen commonly these cases.
See, without any chemical report support, how we could conclude that it is cerebral disorder?
Because, sir, patient is treated for oriented poison, and even the photographs of the fruit and flowers have been recovered from the diseased bone.
No, that is not the helpful evidence, scientific evidence to correlate with the cause of. You could have waited for the chemical analysis, then presented next year. Don't present the same next year.
Thank you, sir.
Sir, stomach is empty, no unusual smell, and mucosa is with patchy congestion.
Thank you, Dr. Kumar. We'll move on to the next presenter, Dr. Fatima Fahi. Her title is A Case of Fatal Cardiac Stab Injury.
Good afternoon, everyone. I am Dr. Fatima Fahmi Shirin, first year PG student. Today I am going to present my poster on the topic Case of Fatal Cardiac Stab Injury under the guidance of Dr. S. Venkat Raghava, Professor and HOD, Department of Forensic Medicine and Toxicology, BMCRI, Bangalore. First of all, let me introduce you to my topic. As we know, stab wounds to the chest are mostly homicidal. Stab injury involving heart has a very low chance of survival. In medical legal practices, the autopsy surgeon has to give opinion about the suicidal or homicidal nature of the death due to stab injury. Analysis of various characteristic features will help us to determine the manner of death. A brief history of my case. A 24-year-old man was brought for autopsy at our forensic medicine department. As per history given by the police, the deceased and his friends were indulged in an online video game in which they bet for 500 rupees. Upon winning the game, a remainder of 50 rupees were to be paid by the lost team to the winning team, which was not paid and which led to an argument. As the argument got heated up, one of the opponent stabbed the deceased on the left side of his chest. Some friends carried him to the hospital, but he collapsed on the way to hospital and was declared dead on arrival on the hospital. Main autopsy findings. As you can see, the dead body was that of an adult male, light brown complexion, moderately built and nourished. He was wearing a blue-colored half-sleeve shirt, which was blood-stained and torn on the left flap of the shirt. Underneath was a white-colored blood-stained sandubani, which was also torn. An oblique stab wound.
Pause for a minute.
Sorry for the interruption. An oblique stab wound, which was thoracic cavity deep, was present on the left side of front of chest. The inner lower end was sharp and the upper end was blunt. Another stab wound, which is subcutaneous tissue deep, was present 10 centimeter away from the stab injury number 1. On careful dissection of the injury number 1, it was seen that it entered the thoracic cavity through third intercostal space, and then it penetrated the left lung upper lobe, and then it penetrated the pericardium through and through, and then it penetrated the pulmonary trunk through and through. The total depth of the wound was 9 centimeter. The pleural cavity contained 1000 ml of blood and blood clots. All other organs were pale. The cause of the death was obtained as death is due to shock and hemorrhage as a result of stab injury sustained to the chest. Discussion. Penetrating cardiac injury is defined as the injury affecting pericardium and its contents. It leads to hemorrhage and cardiac tamponade or a combination of both. In India, it is caused mostly by stabbing instead of gunshot wounds, which is more common in the West. The wound in this case clearly showed that a single-edged knife was used. In this case, a stab injury involved the pulmonary artery, which increased the rate of bleeding. Conclusions derived were: cardiac stab injuries are often fatal due to the vitality of the structure and exsanguinating bleeding that follows. The survival depends on factors like location of injury, involvement of great vessels, urgent transport to the hospital, etc. Even though eyewitnesses were present in this case, oblique placement of the wound, lack of tentative or hesitation marks, etc. favors the homicidal nature. My reference is Anil Agarwal's textbook of forensic medicine and toxicology. Thank you.
Thank you, Dr. Fatima. Forum is open for questions.
Sir, we have a measuring jar with glass jar with labels, say 100 ml and 200 ml and 500 ml. Sir.
Looking at the injury in the photograph, do you think it has entered only the third intercostal space or injured the ribs also? Any rib there?
Yes, sir. For the rib was fractured, sir.
Fractured or cut?
Sir, it was.
Did you examine and report about the third rib injury?
Yes, sir. It was.
Doctor,
Yes, sir.
when we are preparing for this case presentation, you did a literature survey.
Sir?
Did
Yes.
you do any literature survey?
Yes, sir.
What did you search for?
Sir, examination of stab injury.
Examine literature survey?
Sir.
Literature survey, examination. Did you do the autopsy
Yes, sir.
yourself?
Yes, sir.
Okay. I'm concerned with the title. I just want to ask a question. What's the title? Read again title.
Sir, case of fatal cardiac stab injury, sir.
In the history review, did you find any non-fatal stab injuries of the heart? Any reference of your search of literature?
Yes, sir.
Non-fatal stab injuries of the heart.
Sir, I believe so. I have read one.
I'm sorry, not believe. I want evidence. If no, then remove the word fatal.
Yes, sir.
Thank you, Dr. Fatima. Our next.
All the participants of the PG prelims quiz have to stay back in the auditorium. Thank you. attention all delegates. The buses will leave from our college to the banquet venue at 7 o'clock sharp from JSS Medical College campus.
Our next presenter is Dr. Jyoti S. Her title is Corpus Delicti, a case report.
Good evening all and welcome to my presentation. Myself Dr. Jyoti S, third final year postgraduate, Department of Forensic Medicine, Bangalore Medical College and Research Institute, Bangalore. Today I am going to present a case of an young male who was assaulted by an anxious father, thinking that there might be a problem for his daughter by him. When he collapsed, he himself dropped him near the hospital in his auto, where he was survived for 2 hours and he was shifted to mortuary as an unknown body. The dead body is a silent witness who never lies. Hence, the title of my report is Corpus Delicti, a case report. This case report is presenting under the guidance of Dr. Pradeep Kumar MP, Assistant Professor, and Dr. S. Venkataragava, Professor and HOD. Introduction. Corpus delicti is a term from Western jurisprudence referring to the principle that a crime must be proved to have occurred before the person can be convicted of committing that crime. Most of the times, crimes are related to enmity, land disputes, money matters, etc. And at times, crimes is perpetrated to save family honor. Case detail. A 19-year-old male had lost interest in studies due to online classes, and hence he came to Bangalore in search of job 2 months ago. He stayed in his uncle's house and went missing when his uncle went to his relative. A missing complaint was lodged in police station. Hospital record shows police found an unknown person lying in an unconscious state near Victoria Hospital main gate, was shifted to hospital where he survived for 2 hours and shifted to mortuary as an unknown body, and where they diagnosed a head injury. An unknown body with multiple injuries was shifted to mortuary, based on which we suspect a foul play, and the same was informed to the police. Missing complaint, CCTV images and police intimation helped in tracing the identity of the person after 5 days of his death. Case was registered under unnatural death report and under section 174C CRPC. Autopsy findings: dark brown complexion male, bright red stains present over the body, multiple bright red abrasions and diffuse contusion red in color, which is 1 day old injury present at places over face, both upper and lower limbs, and all organs were pale. As we can see in the images, on cut section, blood extravasation present in muscle deep in both upper and lower limbs and over both palms. A split laceration present over top of the head with no evidence of skull fracture, with minimal subdural hemorrhage over right cerebral hemisphere. Discussion: medical evidence play an important role not only in solving the cases, but at times it is a key evidence before the court of law on which the justice is suspended. Studies showed that extensive soft tissue injury or 40 to 50% loss of circulating blood volume can lead to death. In this case, death was due to shock and hemorrhage as a result of multiple injuries sustained. Injury over top of head, defense wound present over both palms, and multiple abrasions and contusion over the body shows that the injuries are homicidal in nature. Hence, based on the postmortem examination findings, the case was registered under crime and it converted into section 302 IPC. This case confirms that the commission of the offense can be well established based on the postmortem examination and by thorough investigation. Picture 1 to 5 shows that after our postmortem examination, the investigating officer interrogated the accused and he revealed the following fact. He followed the accused in image 1. He followed the accused till his home and he hit him with all the weapons available in home. In third image, you can see blood stains over the wall, and in fourth image, he is showing the auto from which he dropped, and fifth image where he dropped. Thank you.
Thank you. Any questions from the audience?
What are the keywords in this picture if you want to publish this article? If you want to send this article for publication, what will be the keywords And that is that reflected in the title.
Multiple injuries, one, and one more is unknown body, corpus delicti, and in poster we need not to put, sir, but in abstract we have to put in keywords.
Palm injury is ideally called. Instead, palm injury.
The blood extravasations. Continue.
What type of injury?
The defense injury.
Thank you, sir. Thank you, Dr. Jyoti. Our next presenter is Dr. China Pati. The title is Fatal Outcome Following Multiple Bee Stings.
Good evening, everyone. I, Dr. China Pati, first year postgraduate, is going to present a poster on the topic Fatal Outcome Following Multiple Bee Stings under the guidance of Dr. S. Venkataraghavan, Professor and HOD, Department of Forensic Medicine and Toxicology, Bangalore Medical College and Research Institute, Bangalore. Death due to insects bite are often encountered during medical legal practices. Insects of the order Hymenoptera, which include bees, wasps, ants, and hornets, are particularly important because of being ubiquitous in the nature, and their stings can result into localized to systemic reactions leading to a fatal outcome. Objectives. Anaphylactic shock is an unexpected, life-threatening, and sometimes fatal occurrence that can affect without a prior history of allergies. Hymenoptera are one of the common causes of hypersensitivity. Hereby presenting a case. As per the history, a beehive was punctured by some birds, and an elderly man who was passing by got stung firstly by 2 bees, after which he fell down and he was attacked by more than 200 bees. Later, he died prior to any treatment. Postmortem findings. On external examination, multiple bee stingers were observed in his face, extremities, and in the groin region. Round, reddish, and raised area can be seen around the stingers. Reddish discoloration of the conjunctiva present. There is no swelling of the lips or neck or any lymph node was enlarged. On internal examination, there is no swelling in the laryngeal area. There is no pulmonary edema. There is no congestion of any organs. Skin samples with the stingers from the inner aspect of the thighs were sent for histopathological examination for localized tissue necrosis and to estimate the increased level of serum tryptase. Opinion as to the cause of the death. Death is due to anaphylactic shock as a result of multiple bee stings. Pathophysiology of bee sting. Type 1 hypersensitivity is defined as the stage of rapidly developing immune response to an antigen, here in a case bee sting. It is mediated by humoral antibodies of IgE type. The reaction appears within 15 to 30 minutes of exposure to antigen. Treatment of the bee stings or anaphylactic shock. Resuscitation and hydration with vascular expansion solution. Localize the stingers and remove it with the help of the tweezer. Morphine and acetaminophen to control pain. High dose of antihistamines and corticosteroids to prevent anaphylaxis. Discussion. Bees leaves in colonies and attack only when they are provoked. The severity of the allergic reactions to insect bites varies according to the individual response and nature of the incidents. Here are my references. Thank you.
Any questions from the audience?
You have mentioned that increased level of serum tryptase. May I know the level? How much you got?
Sir, we didn't got the report, but we expect it to be more than 11.5.
Not correct. No. Please don't.
Thank you.
Scientific forum, please. If you have values put, otherwise don't mention it.
In anaphylactic shock death, do you expect laryngeal edema?
Yes.
Can you identify it at autopsy? When autopsy done, you can appreciate laryngeal edema. When you cannot do, what you should do. Did you send larynx for histopathology?
Thank you, sir. Thank you, Dr. Chainapati. Our last presenter for today, Dr. Hemant Reddy. His title is Hole in the Wall, Gelatin Blast Case.
Good evening, everyone. I am Dr. U.K. Hemant Reddy, first year postgraduate from BMC. Today I am presenting Gelatin Blast case report under the guidance of Dr. S. Venkatrava, Professor and HOD, and Dr. C.N. Sumangala, Professor. Isolated death due to explosion in civil casualties usually in mines and quarries. The autopsy in explosion death needs forensic expertise as the interpretation of the injuries is the most important aspect. Effective autopsy is that in which the cause was ascertainable but was not ascertained due to some constraint on the part of doctor, hospital, facilities, etc. Victim was a blaster working in a quarry. Based on initial complaint, case was registered as RTA, following which the Taluk medical officer has conducted the autopsy for the scene. On suspicion of foul play, the body was brought for the second autopsy to Victoria Hospital 1 day after the first autopsy. On examining the body, the explosion death was suspected and body was sent for prior radiological examination. On external findings, both tympanic membranes were ruptured, disruption of vascular chain, thoracic cavity is disrupted with huge gaping, wound in the chest and back. Dust tatting was present. Multiple punctate lacerations, abrasions, and bruises were noted. Burn injuries were present over chest at places. Multiple lacerations and fractures were noted. Both palms showed black powder residue. Coming to the internal findings, multiple penetrated stone fragments were found over the front of the body at places. Small pieces of heart and lung were present, the rest of the tissue missing. Thoracic vertebrae was transected at T6, T7 with the corresponding spinal cord severed. Liver and spleen show multiple lacerations. Intestines herniated into the thoracic cavity. Hinge fracture of the skull is present. Swabs and cellophane tapes were collected for trace evidences. Missile fragments were demonstrated in radiological examination. Viscera was sent for chemical analysis to rule out intoxication prior to the incident. Coming to the discussion, injuries caused by the primary, secondary, tertiary, and quaternary mechanisms were demonstrated. Impact was mainly focused on the chest and upper limbs. Peppering or Marshall triad over front indicate he was facing the bomb before explosion, and severe damage to the hands and chest indicate that he was bending over the bomb. Lack of trained doctor led to the defective first autopsy. These are my references.
If alcohol is detected in the viscera, what would have been your interpretation? Was it necessary to send for chemical analysis?
The police investigation officer has requested us to collect viscera.
He will request 100 things, no. But as an expert, do you require to send viscera in such cases?
Yeah.
Suppose, okay, you oblige the police. If alcohol was detected, what interpretation you would have given?
So that probably intoxication before incident would have suggested that there was some negligence on the part of the victim itself.
You have mentioned defective autopsy. What is defective autopsy?
So the defective autopsy is that one in which the cause of death was ascertainable, but was not ascertained due to the constraint on part of doctor, facility, or hospital, anything, sir.
I'm sorry, which?
Anil Agarwal, sir.
I'm sorry, I don't agree anything and everything. You get a new term. Is a MBBS doctor legally qualified or no?
Yes, sir.
Then how can you say defective autopsy?
So if there is
No,
constraint on-
can you please read out? I can't read it. Can you make it big screen, please? We can't. 90% of autopsies in India are done by MBBS doctors. Do we call all of them defective autopsies?
No, sir, only if the cause of death was not ascertainable because of some constraint, we call it defective
What is
autopsy.
it constraint? Can you explain? Because you're presenting a paper. Can you explain that
There
constraint?
is lack of training on the part of doctor, lack of knowledge, or there was any lack of facilities.
Who says that?
That it was given in Anil Agarwal.
No, I'm asking. Forget Anil Agarwal. Anil Agarwal is not Bible, no. You are a doctor, already MBBS doctor.
Yes.
You are doing MD,
Yes.
right? Do you agree with the statement of any book will write anything? Do you agree or not when you are present in a scientific forum? You have to discuss in your department, is the statement correct or not? So defective autopsy, you have mentioned that cause was certain. Who said cause was ascertainable? Who says cause was ascertainable, but the first doctor did not ascertain?
There is no reference of that.
That means several.
Do you want to modify the cause of death, what you mentioned? What is the cause of death?
Death is due to multiple injury sustained.
You have presented so many photographs with
It
so
is
many
there, sir.
injuries.
That bottom is not coming in the screens.
Yeah, no, correct. Death due to multiple injuries, that's all. Is it due to blunt force trauma, sharp force trauma? Is it to a blast injury? What is that?
It is due to blasting exposure.
When you have shown so many photographs, when you have defended yourself with all the findings, don't you?
Sir?
Which are the fatal injuries?
Fatal and non-fatal, just mention that.
So the chest injury and skull fracture are fatal, sir. The punctate abrasions present over the body are non-fatal. Sir, we don't know which has happened first. One blast, sir. It was disruption of thoracic cavity, sir. Entered. When that injury to chest, the only piece of heart was recovered. The rest tissue was disintegrated. Yes, sir, we can. Yes, sir. The top photo was the skull suture was done on the first autopsy. Neck is done taken at second autopsy. Sir. The first one, the skull suture, that was done at first autopsy. Sir. No, sir. So the investigation officer has suspicion of some foul play. Yes. Initially, the body was based on the initial complaint and police history. The body was found on the roadsides.
Forensic ballistics would have come to the scene. Road, it was found on the roadside.
Based on police history, sir.
The first photograph showing the head sutured wound.
Yes, sir.
Where was the skull open?
Yes, sir. On frontal area.
Where? Which hospital?
First autopsy, sir. That
first autopsy.
In the external examination, you have mentioned both tympanic membrane ruptured with disruption of ossicular chain. Yeah, that is
no, sir, no, sir. There's otoscopic examinations.
otoscopic.
So we have borrowed otoscope from ENTs. Sir? No, sir.
How did you make out ossicular chain? A disruption of ossicular chain.
The stapes and malice into the protruding outside. So we are able to see a part of bone, sir. So even if single bone is out of that, there is called disruption of ossicular chain.
Okay, when you open up the skull cavity, yes, right? What findings you see in the base of the skull if there is disruption of ossicular chain?
There is middle cranial fossa fractures. No, sir.
Thank you, sir. This will be the last presentation of this session. Thank you, Dr. Hemant. Thank you, Team JSS, for the opportunity. Up to the organizer.
I would now like to invite Dr. Shankar on the stage to felicitate our chairpersons for today. request all PG participants of the prelims of the quiz to stay back in the auditorium itself. One more announcement, when you leave for dinner at 7, please carry your food coupons with you. Entry will be provided with the food coupons only. Thank you. I kindly request all PGs to stay back for their prelims in the same auditorium itself. We'll be beginning momentarily. I hope we have all the PGs assembled here for the prelims. And please occupy the front benches. We'll be starting in 2 minutes. I request all PGs to occupy the front benches. We are starting now.